First off, thank you all. I'm going to give introductory comments in a moment, but I'm going to turn it over to Karen to run us through our roll call and make sure we have all of you know who's here from the commission and remind you, since it's been a little bit of time since we've been together. So Karen, please take it away.
Thank you, Secretary Galley. I just want to check with our crew that we are letting members of the public into the meeting now. Is that right? Okay.
Yes,
wonderful.
that's correct.
Great. Well, thank you, Secretary Galley, so much. This is Karen Bloomer with Leading Resources Incorporated. Just to go through our virtual meeting protocols for the meeting. Just to note, this meeting is being recorded and will be posted as a recording on the Healthy California for All Commission webpage. Commissioners, you are panelists and co-hosts of this meeting, and so you have the ability to mute and unmute and the option to be on video, and we very much appreciate you using your cameras during the full meeting if at all possible. Please do make sure you are muted when you're not speaking, just so we can reduce background noise. To indicate that you'd like to speak, if you have this feature on your Zoom device, please use the raise hand feature. So at the bottom of your Zoom screen, you would see a happy face with reactions button at the bottom. If you click on that, there is another button that says raise hand. So if you click on that, we can get you into an ordered queue and then invite you to unmute to speak. If you don't have this feature or cannot find it, please just unmute and let us know you'd like to be added to the queue. For members of the public, welcome. You can listen to and view this meeting. We will be having a public comment period during this meeting, at which time we will enable the chat feature and we will invite written comment through the chat feature. We will also invite members of the public who wish to speak to use the raise hand feature at that time, and we will take as many verbal speakers as we have time for. And we also invite any and all of you to provide written comment to our email address at healthyca@chhs.ca.gov. All public comment, verbal and written, that's provided during this meeting will be part of the public record, and we will post it on the Commission's webpage next week. Okay, I'm going to move to roll call now. So when I read your name aloud, if Commissioner, if you would please just unmute yourself and say hello so we can see all your faces and know you are here. I'll start with you, Secretary Galley. Welcome.
Present, thank you.
Carmen Comsty.
Present.
Jenny Chin Hansen.
Present.
Sandra Hernandez.
Good afternoon, present.
Bill Shao.
Glad to be here.
Rupa Maria.
Hello, present.
Bob Ross.
Present.
Richard Scheffler.
Present.
Andy Schneider.
Present.
Sarah Phlox.
Present.
Kara Desert.
Present.
Antonia Hernandez.
Present.
Anthony Wright.
Present.
John Molds. John Molds, I see that you're here. Are you able to unmute?
Yeah, is that better?
Much better.
And is there a trick to the video? It's not letting me do that either, which is fine if that's what you want.
No, we'd love to see your face. We'll get working on that. Thank you for letting us know.
Yeah.
Thank you. Richard Pan.
Present.
Tim Wood.
Present.
And Will Lightbourne.
I'm here, present.
Thank you. I'll note that Commissioner Peter Lee let us know in advance that he'd been unable to attend today. So we'll note that as well. And now I'll turn things back to Secretary Galley for his opening remarks.
Thank you, Karen. And again, thank you to all of my co-commissioners. It's been a long time coming. And again, as I reiterated to folks, I want to reiterate what I said in the waiting room, appreciate everyone's patience with us as we get to this moment. But we haven't been without some conversation. Just to remind the public that We've had the privilege of engaging with commissioners throughout one-on-one, getting feedback and having conversations that help us get to today, where we have a opportunity to really envision what the future can look like for healthcare, moving away from what is a fragmented system with Medicare and Medicaid, employer-sponsored coverage, Covered California, and really looking forward to something where we can talk about unified financing. And we know this is an opportunity to think big, think boldly, and be aspirational. Our goal today and moving forward is to better understand the impact and implications of unified financing, by which we mean this bold and dramatic disruption on how healthcare is paid for throughout our state. We know that unified financing is far removed from where we are today, and it's going to take many actions to bring about a system of unified financing in California, and that this is not only in California's control. There can be tension in the pursuit towards this bold goal, and this commission gives us an opportunity to surface some of those differing views, engage in conversation, and push forward respectfully with our commissioners in mind towards something that can be truly transformational. Not sure, Karen, if the slides they're up. Great slide. So the work to date has emphasized really emphasizing on areas where we want to keep moving forward on this goal of understanding unified financing here in California. I just want to remind you that we've had many good conversations where that tension and that rigor of conversation has been apparent, but we have all along agreed on some very important goals and pursuits, including the core values of access and equity, cost containment, that all need to continue to be part of our future conversations. We had previous meetings last year, and then again in June, July, and August via Zoom. I remember at our first in-person meeting, our only in-person meeting, I was pulled away to be on with the CDC to talk about COVID-19 and the repatriation flights that were coming to California. It seems years ago, yet fresh in my mind, the auditorium we were in together, none of us knowing we were on the cusp of this historic pandemic and the moment that we've all been living. In August, that commission discussed considerations around the financing, and we came to some broad consensus on these principles that I just reviewed. Today, we're going to consider analysis from the consulting team that we at California Health and Human Services, with the input of many of you, had a chance to discuss. We're looking at various permutations of unified financing, including issues of cost sharing, the role of intermediaries, and how provider payments can be made. We'll be looking at the question of who authorizes and pays doctors and hospitals, whether that's directly through a single entity or whether there is a role for plans and health systems in developing those networks and paying providers. We'll be looking at the diversion options consistent with the diversity of views that I think are here among us. And I imagine when the commission completes our work that we will have had a healthy exchange of ideas. We'll be guided by the analysis of the consulting team, but also the perspectives of analysis that I know you will bring, each of you as commissioners, to the conversation. And our hope is that we bring ourselves closer to a health system that is accessible, affordable, equitable, and high quality for all Californians. I'll just take a moment to remind us that, and I know that there has been moments of tension. There have been spirited conversations among us, whether in the commission meetings or in our conversations outside of the commission. And I would just say that we value the expertise, the experience, the passion each commissioner brings. You're not here by accident. You're not here to just be passed over in your thinking. We care about integrating so many of the thoughts and the diversity of opinions in that respectful way. I've certainly learned through the response of the pandemic how important it is to appreciate and respect all of our opinions. How do you bring together views from the southernmost part of the state in San Diego together with the northernmost parts of Siskiyou, and the diversity of thoughts and opinions to guide ourselves in a pandemic? And I believe that success and experience demonstrates that these conversations can also be that. I want to just take a moment to remind folks that as we've been in this historic moment, the governor, and now in the hands of legislators, including Doctors Pan and Wood, considering a budget of historic proportions. And within it, I just want to highlight a few things that I think are key for this commission to see as opportunities, as important pieces of the puzzle. Things like our expansion proposal of expanding Medi-Cal for undocumented age-eligible Californians over the age of 60. The additional subsidies that come through our federal supports to Covered California, and the opportunity to take the state provided funding to plan for the future. And then I'll just highlight something that I know I've been deeply involved in, which is children's behavioral health, and calling upon a single system and approach statewide so all 0 to 25-year-olds get the early intervention, the focused behavioral health services that they need in a single system. And I'll just repeat that, in a single system, in a system that says regardless of who supports you, whether you have employer-sponsored insurance, you're on Medicaid, or you have neither, that there is a chance to have a single set of expected services for all young people so their future can be bright. We can then move on to the agenda overview. So we've done our welcomes. We've talked about, we're going to be talking, giving each commissioner a moment to make an opening comment around a structured question that Karen and Eric will share. We will have an overview and discussion of the analytic findings of our our consulting team. Dr. Kronik will be speaking through that, and I know many of you had a chance to review his excellent summary of that work. The breakout group discussions are going to be meaty. I'm looking forward to that, where we'll talk about some of the design considerations and options, and then coming back as a full group for full discussion. And then, as always, we will have a moment around sometime at the end for public comments. I want to just, before moving on, talk about something that was a rich part. Go ahead, next slide, Karen. Talk about the community engagement. We heard loud and clear, and certainly it is my own intent and the spirit that I certainly want to keep bringing to our work, where we ask people what they think in our communities, that we get on the ground. And although it has been important to us all along, figuring that out within the confines of our limited time and work together, we have this process will happen. It will happen independent of the commission itself. The findings will be presented and discussed at our future meetings, and commissioners will be invited to be part of that conversation, webinar, in-depth review of the findings. And of course, these webinars are meant to engage the public, so they will be open. I want to just take a moment to thank a few of our commissioners who have day jobs in important places in philanthropy in California focused on health: the California Endowment, the California Community Foundation, and the California Healthcare Foundation for helping us get this important work off the ground. Next slide. Just to speak a little bit about what lies ahead. So we're here together today. We will have another meeting just in about a month. where we'll have a chance to talk about the design options that will build upon today's conversation, talk a little bit more about the community engagement and get an update there. We will then have, just not too far, 2 months later, another commission meeting where we will continue to refine and evolve that agenda based on the conversations from today and in June. And then a final, working commission meeting in October where we'll synthesize the work and begin to prepare for a final draft, or the draft of the final report that will get circulated with comments from all of you and back and forth. And then likely at the beginning of 2022, so that we can meet our expectation of delivering a report that I can bring forward as your chair to the governor and others early next year, so that we can consider that. So one more meeting likely that isn't listed here. So I just want to take a minute because, and I missed it at the beginning, but we talked about how we haven't been together in quite some time. And the good news is most of you have been here with us throughout this conversation, but Kara Desert is our newest commissioner, and I just want to give her a warm welcome. Certainly as we get commissioner comments, I'll look forward to hearing from her. But we have the same crew we had before, and Kara is a new member of the conversation, and looking forward to inviting her in. So with that, I'll turn it back to you, Karen.
Actually, I'll take it from here, Secretary Galley.
Yeah. Great.
Thank you again. I'm Eric Douglas, a member of the consulting team and facilitator for today. In the spirit of introductions too, I just want to make sure you're all recognizing the other members of our consulting team who are here today. We have Marion Mulkey, who has really been the lead of our team over the last several months. We have Dr. Rick Cronick, who will be presenting later on today. Bobby Wunsch, who has been key in our sort of whole design of this process. And of course, my colleague, Karen Bloomer, whom you've heard from. So again, I'm Eric Douglas. I look forward to facilitating today's discussion. As Mark alluded to, we do have a time carved out now for opening comments by commissioners. And so we have about 25 minutes in which we can hear from each of you, or from those of you who wish to speak briefly. We do have a packed agenda today. And the prompt question, the question we sent out in advance was, help us understand how the events of the past year have affected your views of this idea of a dramatic reordering of healthcare along the lines that Mark described with unified financing and delivery. So would commissioners like to raise their hands and use the raise hands feature? That way we can call on you in queue and hear from you from those who wish to speak. All right, I see Commissioner Pan had his hand up first. So Commissioner Pan.
Actually, I think Bill Shaw had his hand up first, actually.
All right, well, I will turn to you first, and then we'll turn to let's say it's Commissioner Comstes, Commissioner Maria, and then Commissioner Hernandez. And if Commissioner Shaw had his hand up first, we'll call on him as well. So Commissioner Pan.
Oh, certainly it's good to see everyone back again. I think COVID certainly highlighted a lot of issues. Perhaps one interesting issue is that the political will to actually finance our public health system, which is essentially a single payer, unified financing. I don't know, it depends how you want to call it unified or not. It's different levels of government, and the challenges we've had in trying to fund and support that system, and the political will or lack of political will to sufficiently finance that, and the consequence of that when we had COVID. I think the other thing, although we knew this before COVID, is certainly as an elected official, I'm a strong believer in democracy. I would also make note, depending on the nature of the political leadership and the decisions they make and their willingness to accept reality or not, that's going to have a big impact on any government agencies or government financing of efforts as well. And I think we saw that very much highlighted during COVID as well. And I think those are lessons we need to keep in mind among many other lessons as we move forward. But thank you.
Thank you. Commissioner Comsty.
Did you want to go to Professor Shao first, or?
Well, I think in the order of hands is actually showing up on my screen as you going
Okay.
next. And so if you could go next, that'd be great.
Sure. To answer the question posed, the pandemic has made it so that lawmakers, including the ones here on this commission, can no longer feign the ignorance to the unconscionable healthcare disparities and the enduring destructive and deadly economic and racial gaps in our fragmented system of private health insurance. And the pandemic has just furthered my resolve to ensure that this commission provide a clear design model for single payer healthcare that guarantees healthcare for all Californians as a right, and to ensure that this commission does our job to further the discussion on single payer, further regulation and reform of our multi-payer health system of insurance plans is not enough and will cost lives, and it will cost lives that we know will disproportionately be the lives of Black and Brown people. And I wanted to take this time to remind us all that the commission's legislative mandate to identify for the governor and the legislature is to identify transformative solutions necessary to reimagine our broken healthcare system, including the solution of single payer healthcare for all. And it's incredibly important that we have the detailed debate and discussions necessary with this commission as a whole on these design options. As a commission, we're tasked to offer solutions, not to sit on our hands. And I refuse to accept the notion that creating a single payer system in the state of California is a futile task. And I refuse to bargain against the lives of the people of the state of California and allow this commission to present options that will continue our fragmented system of healthcare denial. I wanted to mention two things that I already asked of the consulting team. So I've asked them to model the current single payer legislation on the table, AB 1400, introduced by Assemblymember Ash Kalra. And I sent a detailed letter asking them to model AB 1400 and just received a response last night from the consulting team. And I appreciate the response, but these discussions and debates on modeling should happen in public view. But we're not doing that right now. And second, it's important that as part of our work, the commission respond to the overwhelming questions raised by the legislature on financing a single payer system in our state. The commission must present to the governor and legislature a menu of scenarios for financing and generating new revenue for single payer in California. And I requested that the consulting team create an interactive online calculator showing what different combinations of financing plans may look like in the aggregate, so we can start this discussion on financing with lawmakers and the public in earnest, because we have this opportunity to get this discussion off the ground. But I want to talk about the continued issues with the process of our work. The incredible task that we've been given requires robust discussions among all of us commissioners that are transparent and that have public input. But I continue to have very little understanding about the expertise and viewpoints of my colleagues on this commission. And unfortunately, the consulting team, they put a lot of work in this, but they've been given an outsized role, and they continue to make substantive decisions on the commission's work without sufficient public explanation or explanation to the commissioners. As a commissioner, I have a very muddy understanding of how or why the consulting team has chosen the design options it is presenting today. And I have received no assurances that the potential disagreements and opinions of commissioners, which we know we all will not agree on the design options. I received no assurances that these will be explicitly stated in the final report. And we need to listen to the criticisms that we've heard from the public on our work, and we need to make every effort to avoid another truncated process of the commission's final report. Discussion and debate must be public and not limited to our current process of one-on-one non-public meetings with the consulting team or breakout groups where I don't know what other commissioners have discussed, or arbitrarily limited meetings. And the limitations on public review or commissioner review of the consulting team's modeling process and assumptions and data and decision-making will result in justifiable public mistrust of our work here on the commission. So I implore Chairman Galley to fix this process so we can do our work together as a commission and we can do it well and do it publicly. So I'll leave other comments for later.
Thank you. Thank you, Commissioner Comsty. Secretary Galley, would you want to respond at all to what Commissioner
Yeah.
Comsty said?
And I want to make sure we give plenty of time for other comments as well. But I want to first acknowledge the comments and hear again the opinion and the weight of those comments. I think we want to create an environment where we have plenty of room for conversations. We also, I just want it to be clear that we have a limited time. We have a need to move forward with our work, and the agency, through my leadership and our team and thoughtful conversations, did choose to give our consulting team direction on how to focus their analysis and where to spend the time in order for us to be able to stay in a focused way, but yet allow us to have a rich and diverse conversation. I think we've chosen to get to this point. We have tried to be mindful of all the work that so many, not just in the state and local governments that have been focused on during the pandemic, but many of you, to give us ample time to get to a place where we would be able to have today's conversation and set it up as a part of a series of conversations. And that those individual one-on-one conversations were meant to make sure we didn't have total absent conversation over the last many months, that we get people's perspective. And I can understand that some commissioners may find this insufficient and not enough time. And we are certainly open to how we use the somewhat limited number of meetings and opportunities for engagement to make sure that they are as enriched and enlivened as we can. Today's agenda is an intent to do that. The focus on breakout rooms and giving people ample time to share their experiences and then come back together, I think, is one approach on facilitating that is effective. It doesn't, none of these approaches are perfect, but I think for the sake of getting us to a place where we can have a rich and comprehensive and complete conversation, we've chosen to go the way we have. I would just say that I appreciated the letter and note that you provided, Commissioner Consi, and the response to that letter is not meant to end the conversation, but to continue it. And I think we will. I do just want to say, because you're not the only one who raised the legislation that had been proposed by Assemblymember Kalra, AB 1400, that we are not going to, in this setting, discuss active or even potentially active legislation, because that is the job of the legislature and that process should continue. That said, I think many points in this conversation today and as we move forward will help inform not just the thinking of legislators, but of many others who will be part of that conversation at the right time when it does happen. So I'm happy to continue to engage. I take the responsibility of ensuring that we move with the diversity of opinions and interests as thoughtfully as we can. And whether that is in the setting of the meeting or whether that is outside of the meeting as well, I'm happy to continue these conversations. So with that, I know we have many other commissioners who want to make some comments, but thank you for a few minutes to respond.
Thank you, Secretary Galley. So we actually have two commissioners in the queue. And I want to just be mindful of the clock. We have a very busy agenda today. So we have about 10 minutes remaining for commissioner comment. And Commissioner Maria, you are up next.
Thank you. First, I want to acknowledge the land from where I'm speaking to you, the Ohlone territory of Huichin, what is now called Oakland. I'm grateful every day I wake up here. Over the last year, working in the hospital at UCSF on the front line of the COVID pandemic, I have appreciated how historic and critical the hard work of imagining a new system of healthcare delivery and financing for Californians is. This year has shown me how a fragmented healthcare system does not meet our needs for our patients or our providers, and how private insurance fails us in the face of devastating wildfires and a pandemic whose long-term impact we have yet to understand. This past year has cemented my commitment to see that this commission makes single payer happen in California, not in a few years, but now. Like Commissioner Comsty, I also want to raise my concerns about the process by which this commission has been conducted thus far. I have raised these concerns several times with the consultants and haven't seen them addressed, so I want to bring them up now because they are germane to our work together. The external consultants who have been hired with taxpayer dollars have been controlling this process. I believe their work has been provided a lot of valuable input, but how they shape the process has also obstructed our ability to do the hard work of imagining together. And that is the mandate of our charter. The commissioners must be able to discuss and debate the best path forward for unified financing outside of the control and assumptions of the consultants. Right now, we are given 3 to 5 minute segments to make statements, but there has actually been no space at all for us to have back and forth dialogue, discussion, debate, or conversation, as Secretary Galley just mentioned. There's been no space to challenge each other's thoughts and to come to new understandings together. The consultants have been interviewing us individually and privately, and then compiling reports based on what we have said. The reports include language like some commissioners say this and other commissioners say that. The process is hidden from our view and even more so from the public. The draft analysis report given to us earlier this year is still not public. It is typical for commissions and boards of this type to have full and open dialogue. This is the precedent that these bodies follow and that the public expects. And so it has been surprising and disturbing to me to see the degree of privacy and filtering happening on this commission. We are here to develop a plan to transform healthcare in California, not just to cover everyone, but to center equity. Thousands of people of California have lost loved ones and suffer now under the phenomenon of long COVID. Many are unemployed or have fallen through the cracks, and when that happens, their health and their family's health suffer. It is of utmost importance that this process be transparent and public, and it has been neither. Even though the consultants have interviewed us privately to gather and compile our thoughts, I have noticed that many of my concerns and comments have gone missing in their analyses. They are filtering what to report to the full commission and to the public. In this historic moment, I have to wonder about the dynamics of racism. As one of the only few women of color on this commission, I am only one of the few women of color on this commission, and my voice often goes missing in their reports. The consultants are all white. I am also one of the only practicing clinicians who has worked in the hospital at the bedside through this pandemic. My lived experience speaks volumes for our need for transformational action now. We must have the ability as commissioners to meet for as long as we need to dialogue, discuss, and debate the best way forward for unified financing in the state of California. Dialogue without the circumscribed limits set by the consultants will allow us each to hear each other's concerns, address them, and reach creative solutions and consensus. Through our public discussion, we can be accountable for our ideas and move towards the most reasonable approach to meet our goal for a responsible unified financing plan that advances both access and equity. I motion to put a vote to my fellow commissioners. I propose we set up more meetings whose sole purpose is discussion and debate between the commissioners in public, unmediated by the consultants, so that we and the public can hear what each of us think about unified financing, and so that we are no longer hindered in our ability to do what we are supposed to under our charter and legislative mandate. I want to hear what you're thinking directly, and I want to discuss and debate it together. Thank you.
Thank you, Commissioner Moya.
Eric, I'd like just a second chair prerogative to respond as
Yes,
well.
please.
First off, and again, both for Commissioner Comsty and Maria, I think we want to make sure that it's clear that certainly the direction that the consultants have taken to date has come from me and my team trying to figure out the path forward that allows us to get to a place where we have a product, a meaningful product that we can provide to the governor and the legislature in the timeline that we have laid out. So in case you or other commissioners believe that there is a role that our consulting team has over the overall process and product and the way that we are working, it is, of course, their professional experience and their work and history in this space are valued. That's why they were selected to help. But at the same time, ultimately, it is me and my team helping guide where that work goes. And again, the conversations that we had over the last few months, individual as they were meant to keep engagement going in lieu of waiting with no conversations until this moment. So I know there's other commissioners and I want to be mindful of the process, and I don't want to dismiss those comments, right? And I want people to be feel heard. I know that I intend, as I have even as of the last day, to make contact to talk through some of the concerns and ideas, and certainly the vote or the motion that you put on the table want to be able to have a conversation on how we achieve some of those desires and opportunities. And I think it is valuable to have that open dialogue, and I hope we can achieve some of that today.
Can I
Second, the
respond to
motion
that?
on the table? Oh,
Yes,
sorry.
I'd like to respond to that. I appreciate that, Mark and Dr. Galley, Secretary Galley, but I've also been bringing up these concerns for several months, talking to consultants several times. And yesterday at night was the first time you reached out to me to address it. And I appreciate that. But I also feel like there's, our process must be above the board. It's too high. This conversation is of too high stakes. As a physician, as a provider who has been watching and ushering patients through this pandemic, it is unconscionable to me that these discussions are not happening in public, that I don't know what each one of my fellow commissioner thinks. While I understand and respect your leadership, I was appointed by the governor to do this job, and I'm not able to actually do my job if I cannot have substantive discussion, dialogue, and debate with my fellow commissioners. And there has been no situation where that has been possible. We are legally bound by the Opens Meetings code not to meet together outside of this setting. And this setting is completely controlled by you and the consultants. So I ask for us to vote. Do my fellow commissioners want to have more meetings where we can just actively, openly debate each other in public about these options that are presented today?
So let me go ahead if I can. I want to make sure, Secretary Galley, that we do hear from other commissioners today. So Commissioner Shao, you had your hand up earlier, and I would like to hear from you.
Well, I'm delighted that we're meeting again. And this terrible year really put us intensely focused on the need for California to move to a single payer system. And I'm determined to do my best to assist you. But meanwhile, I like to actually take what Carmen and Maya have said one step further in very concrete terms. Yes, Secretary Galley, I appreciate your excise leadership, but you have been extremely busy with, I'm sure, and with all the pandemic. And also, let me give you a concrete example. We received the agenda for today's meeting, telling us the 5 major issues we should discuss in breakout groups. But let me share my 40 years of experience on single payer designs. The key issue is what designs may make the program affordable. Single payer's major attraction, well, besides being universal, equitable, and so forth, is it will save the United States and California money. But it's not on your issue agenda. When I received that, I said, my gosh, who is determining the agenda and guiding us? And where's my voice? So I respect your leadership, but you're not getting the right input and you're not giving the commissioner even comment. So we can determine the agenda for the commission. Thank you.
And I know that Commissioner Sandra Hernandez, you had your hand up earlier. Did you wish to still make a comment, Commissioner Hernandez?
Yeah, I was going to respond to the question that was posed and really was listening to this previous conversation, Eric. I'm actually anxious to get into the substance of the meeting, notwithstanding these process issues that have been addressed. And the only point I was going to make is that, and this really builds on something Senator Pan said, and that is that the pandemic clearly showed that you cannot think about the public health system separate from the delivery system. And thus the fragmentation that we have seen us all struggle with through this pandemic is further fragmented by the fact that we have a public health system that is largely not at all integrated financially or otherwise within our delivery system. And it seems to me it makes our work all that much harder.
Thank you very much, Commissioner Hernandez. Commissioner Ross, I see you have a hand up.
Yeah, thank you, Bob Ross here. And number one, just Mark, thank you for your navigation and stewardship of the most difficult public health crisis our state has faced in a century. So just appreciate you and all the public officials and public employees have done to try and stem the tide of this terrible pandemic. Yeah, for me, absolutely. I think for me, my resolve is, and I'm already hearing it in some of the early comments from commissioners, you know, for us to be stubborn as a mule about the vision. And the vision for me is three things: everybody in, nobody left out, unified financing mechanism, and advancing racial and health equity. Underneath that, I'm adaptive and open and about the roadmap and how we get there. And I actually believe some of the work of the consultants has been quite good in lifting up some of the issues. But I also agree, Chairman Galley, that we will need more time to debate these issues. And I look forward to being shaped and influenced by both the passion and the skills and the intellect of the folks on this commission and what we hear from the public about developing the roadmap. But yeah, let's be stubborn about the vision, even more stubborn about the vision because of the pandemic and all the racial and structural inequality that is unmasked. But at the same time, let's be open to hearing one another about the roadmap to getting. Thank you.
Thank you, Commissioner Ross. So I recognize that there is a motion on the table from Commissioner Comsty. And I would like to exercise at this hour in the agenda, we had called for a quick break. So we're going to take a 5-minute break at this point, and we'll come back after the break and we will talk about the motion that's on the table from Commissioner Comsty. So we will see you back here at, it's now 1:48. Let's give ourselves a total of 10 minutes. We'll come back right at the hour of 2 o'clock and re-adjourn. Resume our meeting. Thank you. So 2 o'clock, we'll see you back here. Well, so if we could have everybody come back to the meeting, we'll go ahead and I misspoke. The motion that was on the table was a motion from Commissioner Maria with regard to wanting more meetings and I believe also more open process for the commission. And I think at this point, it would be the chair to sort of discern what we should do at this point. And so I will turn the microphone over to Secretary Galley.
Yeah, first, thank you. And I expect everybody's back on. So want to appreciate the conversation we just had and suggest that in light of the motion and discussion that so we can continue moving forward with some parts of today's conversation, which I will get to in just a minute, that we immediately after this meeting provide a transparent, clear poll for all voting members. Not every member of the commission is a voting member, to kind of opine on the number of meetings that we have scheduled. I've laid out a meeting schedule that includes 3 more substantive meetings and then a meeting with to review the report and to determine the will of the group to meet more frequently, more hours in total, to continue to have a conversation that I'll say could be more robust. And then as part of that, and I want to make sure I get Rupa, the motion correct, not just the number of meetings, but the process by which those meetings are held. So being able to lay that out and do a transparent poll that votes will be received from every voting member, and the vote will be made public, not just with the vote itself, but also with the potential to explain any explanation to the vote that's being cast. And then based on that, we will be able to, it will give me a chance to understand what we'll need in terms of resources and structure and time to be able to meet the will of the group. But we want to honor that, and I think it's important, and heard it not just from you who made the motion, Rupa, but also many other commissioners just in the short period of time we had comment. And then for today, so I'll come to that in a second, just get some reflections on that in a moment. But for today, I had a chance during the break, reached out to our consulting team with the recommendation that although there are some, as I mentioned, reasons to do breakouts, gives more people time to talk and share their view in a limited amount of time and then bringing it together, that we will not break into breakout groups, but try to, as a full commission, have the conversation. So every commissioner has the benefit of hearing directly, not as a single report, but as a commission. I think we can still get through many of the issues and hopefully give people a chance to speak up. And for that, I would just ask commissioners, given the time we have on hand, to keep their comments as concise as possible so their other commissioners can share their view. So with that, Eric, I just propose that we do that and see where we can take it from here.
Mm-hmm. I think our team is happy to adjust to that, Secretary Galley, and look forward to that discussion later on today. With the Commission's permission, I would like to make sure we stay on track, though, with regard to our timing. I don't see any hands up at this point, and so what I'd like to do is ask Marianne Mulkey from our consulting team to go forward with the summary of the findings from some of the interviews that we did conduct with commissioners. This is a chance to hear that full panoply of viewpoint, and then we'll move on to the presentation from Dr. Kronig. Marianne?
Well, thank you, Eric, and I appreciate the opportunity to be with you all today and to continue to serve in this consulting role to assist this commission's important work. We're going to turn shortly to Rick Kronig to present the consulting team's initial analytic findings. But I first wanted to offer a little context based on the input that all of the commissioners generously offered the consulting team about 6 weeks ago. Next slide, please. As was mentioned earlier, between March and mid-April, 2 or more of the consulting teams did have an opportunity to speak with each commissioner, and we appreciated those opportunities very much. We focused primarily on the analytic framework and the key assumptions that went into the initial analysis that Rick will be presenting to you. In addition to the thoughtful input offered during those conversations, we've received some follow-up suggestions, as was previously mentioned. Particularly noteworthy and appreciated by the consulting team were the extensive comments that Commissioner Comsty sent to us about 10 days ago. Next slide, please. The initial outline presented by the analytic team proposed to model 2 alternative structures. One focusing on direct payments from the Unified Financing Authority to providers, and one involving health plans or health systems as intermediaries. When we talked to commissioners, we found that most commissioners supported an analysis that considered and compared those two alternatives, although we did hear some strongly held preferences for one versus another, and I'm sure we'll continue to hear those today. Two related topics that came up frequently in these calls involved just what roles the intermediaries would play, how those roles might be similar or different to the roles that health plans and medical groups in California play today, and how payments would be structured, whether through fee-for-service or capitation, value-based payments, or some hybrid. An additional theme that was raised by several commissioners involved concerns about the intended outcomes and benefits of unified financing. They rightly noted that total spending and people covered are by no means the only outcomes of interest, and they urged the team to consider other outcomes such as equity, quality of care, and health clinical outcomes alongside those metrics. So as you'll see when we turn to Rick's presentation, the research team took this input into consideration and is prepared to continue to receive suggestions and refine the analysis based on the comments we hear today and those after this meeting. I will also note that in our conversations, a number of commissioners questioned some or many of the premises and assumptions that were part of our analytic approach. Next slide, please. Several commissioners indicated that the sweeping changes required to establish a new California system of unified financing seemed quite ambitious. They felt that other steps they thought might potentially be more attainable might also merit the consideration of this commission. Some commissioners suggested building blocks in the forms of policy changes, information systems. Others offered ideas about more incremental approaches that they felt might better align with potential federal approvals. We appreciate and acknowledge these comments. However, today, as Secretary Galley noted at the outset of the meeting, we're focused on the potential impact of comprehensive unified financing, that broad reorganization of our fragmented financing system. So again, with appreciation for the opportunity to be with you and for your continued thoughtful input, I'll turn to Rick Cronick, who's led the consulting team's research effort, to share an overview of the findings.
Thank you, Marion. I'm excited that the commission has resumed meeting and to support the commission in accomplishing its task of providing the legislature and the governor with design options for unified financing. The consulting team has produced estimates of the effects of a variety of scenarios for unified financing on healthcare coverage, costs, and equity. And it's my pleasure to present that work today. Next slide, please. This has been a team effort. Members of the team are listed here. I particularly want to acknowledge and thank Laura Lucia from the UC Berkeley Labor Center, who has been the backbone of this effort. Next slide, please. As Secretary Galley said, I just want to start with a reminder of what we mean by unified financing. We refer to a system in which all Californians would be covered for a comprehensive package of benefits by virtue of being Californians. The distinctions among existing programs would be eliminated. And unlike the status quo, whether someone is covered and what they are covered for would not depend on a person's age, employment status, income, disability status, or other characteristics. To achieve unified financing, the federal government would need to agree to change the rules that govern and would need to write checks to the state in lieu of the money that would otherwise have been used to support Medicare and Medi-Cal beneficiaries. And it's important to recognize at the outset that even a friendly Biden administration could not agree to make these changes on its own by approving waivers. Changes in federal law would be needed, certainly to allow the participation of Medicare and almost certainly for Medicaid as well. And as Marion said, in talks with commissioners prior to this meeting, many commissioners told us that they thought it was extremely unlikely that Congress would enact anytime soon the statutory changes that would be needed to allow unified financing to be implemented in California. But many of you also acknowledged a chicken and egg problem. While many commissioners thought it was unlikely that Congress will change federal law to allow California to adopt unified financing, it's clear there's virtually no chance that Congress will do so unless California has a well-developed blueprint of how unified financing will be implemented. And thus, even many
Dr. Cronin, can I
commissions-
interrupt? Dr. Cronin, can I interrupt for 1 second? There's a sound that your lapel mic, I think, is making on our
Oh,
audio,
I'm so sorry.
and it's interrupting our ability to hear you clearly. So if I could just ask you to perhaps adjust so that we're
Okay,
only,
let me see. Is
not
that
hearing
is
that.
that any better?
I think it's much better. Yes, thank
Okay.
you.
And thus, so even, many of the commissioners who were skeptical that developing such a blueprint would result in positive change were supportive of the notion that developing such a blueprint would prove useful in the event that an opportunity for congressional action were to present itself. Next slide, please. I'll start with a summary of the results. Usually the results are at the end, but I'm going to start at the beginning. Under unified financing, all Californians would be covered for a comprehensive package of services. Care would be more equitably delivered, and we would certainly not spend more money and very likely spend less money, and certainly great likelihood or possibilities of reducing the rate of growth of spending over time. No surprise here, I think, consistent with the results of many other analyses, that unified financing, if we can get there, would be a tremendous improvement over the status quo for Californians. Next slide, please. This slide shows an overview of the 4 topics to be covered. Let's go to the next slide, please. And the next one, we'll start with assumptions about how unified financing might be implemented. There are many ways that unified financing could be designed and implemented. I'm going to describe at a very high level a few scenarios for covered benefits, cost sharing, and other items on this slide. The purpose of analyzing these scenarios is to provide some grounding for the conversations that you will be conducting moving forward. We are open to providing estimates for other scenarios. I want to emphasize, in response to comments made earlier, that this is a starting point and we've got to start somewhere. Next slide, please. For covered benefits, we provide estimates for 2 scenarios. We provide estimates for a comprehensive package of benefits, including essential health benefits as defined in the ACA, with the addition of adult dental services. We also provide estimates for the addition of long-term services and supports, including both institutional and non-institutional long-term care. Next slide, please. For patient cost sharing, we provide estimates for 2 scenarios, one with no cost sharing and one with income-related cost sharing, which there would be no cost sharing for families below 138% of the federal poverty level, 94% actuarial value, meaning that the Unified Financing Authority would pay on average 94% of the cost, and patients would pay on average 6% for households between 138 and 400% of FPL, and 85% actuarial value above 400%. Next slide, please. On provider payment, we provide estimates for a scenario in which the aggregate payments to hospitals, physicians, and other healthcare providers would be at levels equal to the weighted average of current payments when we look across payers, minus the estimated reductions in costs due to reduced billing and insurance-related costs. Again, other assumptions could be made, and we're open to other suggestions. This is a starting place. We also assume that drug payment policies such as international reference pricing or the aggressive negotiations that are conducted by the Veterans Administration would be implemented. Next slide, please. On the role, if any, for intermediaries, we provide estimates for 2 scenarios again. The first, similar to Canada, in which Californians could choose to receive services from any licensed physician or hospital. As it says here in this scenario, payments to physicians and other non-institutional providers would largely be made on a fee-for-service basis. Hospitals would be paid based on global budgets. And the second scenario, somewhat similar to Medicare Advantage, covered California and models in parts of Europe, in which all Californians would enroll in a health plan or a health system. Each plan or system would offer the same set of benefits and the same cost sharing if cost sharing were used. Plans and systems would be paid a risk-adjusted capitation, that is a fixed amount of money for each patient who is enrolled. I want to emphasize that in the scenario where intermediaries would be used, this might sound like the status quo to some, but unlike the status quo, there'd be uniformity in covered benefits, in provider payment rates, and cost sharing across health plans or across health systems, quite different from what we have today. Next slide, please. On the rated growth of health spending over time, again, we estimate two scenarios. One, where health spending grows at the projected rate of growth of national health expenditures minus 0.5% a year. And second, where health spending would grow at the rate of growth of the gross domestic product, which is about 1.3% a year less than national health spending growth. Next slide, please. I want to move to a couple of slides on the approach to estimating the effects of unified financing. Next slide, please. Our approach, no surprise, we are social scientists, is evidence-based. We draw on the evidence to the extent that we can. We rely heavily on estimates made by the Congressional Budget Office, adapted to the unique environment in California. We are unable to directly model the effects of unified financing on many important outcomes. I'll talk about that more towards the end. All estimates that we provide, like any estimates that made by anyone in this space, are subject to substantial uncertainty. We do have decades of health services research to provide guidance, but we simply do not know with any certainty how patients and providers will respond to the markedly changed environment envisioned in unified financing. Next slide, please. I talked on the last slide about effects that we're not estimating. This slide and the next list some of the effects that we are estimating. In the interest of time, I'm not going to read through these. They're very similar to the effects that are estimated by many other analysts engaged in this sort of enterprise. Next slide, please. I do want to call out two areas that are a little different than some other work. We do estimate changes in healthcare spending due to less use of capitation and the unwinding of managed care in the scenario based on direct payment. So I think everyone knows California makes very heavy use of managed care today. Direct payment would be quite different. And we also estimate the cost for funding reserves that would be needed to operate, to implement a system of unified financing in California. Next slide, please. We want to now move to results, finally. Next slide, please. I'm going to first present results on aggregate health spending under a variety of scenarios, and then present results on other outcomes. So under the status quo, health spending is projected to be 15.4% of the gross state product in 2022, about $517 billion. If unified financing were implemented in 2022, under the scenario with direct payment to providers, no cost sharing for patients, and without expanding long-term services and support benefits, we estimate that health spending would be slightly lower than it would be in the status quo, a difference of a few $1 billion, or about 0.1% of gross state product. We also estimate that spending would be very similar in a scenario that uses health plans or health systems as intermediaries as it would be in the direct payment scenario. And in a few slides, I'll show the pluses and minuses underlying these estimates. Next slide, please. The decision about whether there will be patient cost sharing does affect estimated aggregate spending somewhat. As you can see on this slide, estimated spending in the scenario with some patient cost sharing is 14.6% of gross state product, about 5% or 25 billion lower than in the scenario without cost sharing. Important to note that unlike in the status quo, cost sharing would be strongly related to income. In the status quo, it's higher income people with employer-sponsored insurance who have better benefits and lower out-of-pocket costs than lower income employees. In the unified financing scenario, that story would be reversed with less cost sharing for lower income Californians and moderate levels of cost sharing for higher income Californians. Next slide, please. Relying entirely on an estimate from the Congressional Budget Office, estimated spending with an expanded LTSS benefit would be somewhat higher, again, about 5% of health spending or $25 billion than in a $25 billion than in a scenario without an expanded LTSS benefits. I should emphasize there's even more uncertainty in this estimate than in the others I have presented, both because the Commission has not discussed at all how an expanded LTSS benefit might be designed, and also because we have very little evidence about how providers and patients would respond to an expanded benefit. Next slide, please. The estimates on the previous slides were for 2022. This slide shows estimated spending 10 years after program implementation. Under the status quo, health spending is projected to increase from 15.4% of gross state product to 17.1%. Under unified financing, if spending grows at the rate of growth of the rest of the economy, it would remain constant at 15.3%. If health spending were to grow 0.5% per year more slowly than projected spending nationwide, it would be 16.3% of gross state product in the scenario with no cost sharing and without long-term services and supports, still substantially less than projections in the status quo. Moderating cost growth, healthcare cost growth, is clearly one of the key problems that we face in the status quo and will be a major challenge under unified financing as well. There is nothing magic about unified financing that will necessarily lead to lower cost growth than in the status quo. But unified financing provides both additional levers to reduce cost growth and a stronger imperative to do so. Cost growth in Canada and Western Europe, where unified financing is the norm, is somewhat slower than in the United States. The ability to control prices, as in Medicare today, will provide the Unified Financing Authority a lever that simply doesn't exist today for private insurers. However, there are limits on how much difference there can be between prices in California and prices in the rest of the nation. If nurse salaries or physician income are much lower in California than in the rest of the nation, it will be hard to attract and retain a high quality workforce. To be successful over a sustained period of time, the Unified Financing Authority will also need to figure out how to reduce low value care and how to reduce fraud and abuse. Again, the tools available to the Unified Financing Authority increase the likelihood that it will be successful, but there are no guarantees here, and the success will be influenced by decisions made on governance, on accountability, and the incentives created by the payment systems. Next slide, please. This slide shows estimates for the scenario with expanded long-term services and support benefits, and shows that even with expanded LTSS, without cost sharing for patients, and without cost sharing for patients, it is likely that we would be spending less money on healthcare in 10 years than we would under the status quo. Next slide, please. 2 slides now on pluses and minuses. I showed earlier the estimate that spending would be slightly lower under the direct payment scenario than under the status quo, 15.3% compared to 15.4% of gross state product. This slide shows the components of that estimate, the pluses and minuses. The main story is that spending increases a bit because of insuring the uninsured, quite a bit from eliminating cost sharing, although less in the second scenario where some cost sharing is used, and also increases from unwinding managed care. Balancing those increases, we estimate substantial reductions in spending from lower drug prices, and similar to other analyses, substantial reductions in payer administrative costs, as well as in billing and insurance related costs for hospital and physicians. We estimate a small increase in spending to fund reserves, and as I said earlier, a net change in spending pretty close to zero, a little bit of savings, not tremendous. Next slide, please. I also showed earlier that the estimate that health spending under direct payment and in the use of health systems or health plans as intermediaries is expected to be similar. And this slide shows the components of that estimate. Under direct payment, administrative costs would be lower, but utilization and spending on medical services are expected to be higher. While if health plans or health systems are used as intermediaries, We expect administrative costs will be somewhat higher, although still substantial savings from the status quo, but utilization would be somewhat lower than under direct payment. And as I said earlier, we estimate these two effects will more or less balance each other out. And while the spending might be similar, there are clearly many different implications for how healthcare might be delivered. And I'm sure there will be lively and robust conversations about the advantages and disadvantages of these two approaches. Before moving on to estimates of the effects of unified financing on outcomes other than health spending, I do want to comment on the estimates that I've just presented. I am sure that some analysts will think we've underestimated the savings from unified financing or overestimating the additional costs, and that the unified financing will save a lot more money than we have estimated here. And other analysts are likely to think the opposite. Similarly, some may think that direct payment is bound to be less expensive than using health plans or health systems, and others also may think the opposite. I am hopeful that commissioners and the public will not obsess on these estimates and not put too much effort into arguing about their accuracy. The main task of the commission is to provide the governor and the legislature with design options for unified financing and to help those decision makers understand the implications of those options for access, costs, and quality. There are certainly design options, for example, substantial reductions in provider payment rates that would result in larger estimated savings. It is also certainly the case that other analysts would provide different estimates of savings for the scenarios that we have analyzed. But imagine that this analysis, instead of estimating the very small savings in 2022 that we've estimated for a particular scenario, had instead estimated a 3% or a 5% reduction in spending. Would that estimate really change policymakers' judgments about the desirability or feasibility of implementing unified financing? I doubt it. Others might disagree. And that, I think, is a major reason that I would implore commissioners and the public to not spend too much effort picking apart these estimates. Next slide, please. The next slides show estimates of the effects of unified financing on other outcomes of interest. Unified financing would create universal coverage. No longer would millions of Californians be uninsured. The fraction of Californians with a usual source of care would increase. The number of deaths would decline. Next slide, please. The total number of Californians with at least one physician visit per year would increase by approximately 1 million, and the percentage of Californians reporting problems paying bills would decline. Next slide, please. Similarly, the fraction of Californians who report experience an access problem because of cost would decline. Next slide, please. Some of the beneficial effects on the last few slides could be achieved by achieving universal coverage without taking the extremely disruptive step of moving to unified financing. As an alternative to unified financing, California could build on our current fragmented financing system and achieve something close to universal coverage, while leaving the basic structure of Medi-Cal, Medicare, employer-sponsored insurance, and the individual market in place. But building on this current fragmented financing system could not achieve many other benefits that are made possible by unified financing. Under fragmented financing, we will continue to waste lots of money in administrative costs. It will still be very difficult to restrain the rate of growth of health spending, which will still be difficult under unified financing, but more tools and possibilities to do so. And given the restrictions created by federal ERISA law, millions of Californians with employer-sponsored insurance will continue to face high out-of-pocket costs. Most fundamentally, the inequities that fragmented financing creates can only be addressed under unified financing. Under unified financing, access to care for Medi-Cal beneficiaries would increase substantially. Next slide, please. As we've already discussed, unified financing would result in substantial reductions in time and money that hospitals, physicians, patients, and payers spend on administrative activities. Next slide, please. With the addition of adult dental benefits under unified financing would result in improvements in oral and arguably in physical health. Next slide, please. I want to move to a listing of areas in which decisions would be needed about how to implement unified financing, which is the task in front of the commission. Next slide, please. I list on this slide some of the major areas in which design options are needed. And in response to Commissioner Shao's earlier comments, these issues are, in my understanding, at least, the issues that will affect how much savings are created and rate of growth over time. But we certainly look forward to yours and comments from all the commissioners about, what areas you think are important for the commission to be delving into in a deeper dive. As Marion mentioned earlier, a number of commissioners encouraged us to estimate the effects of unified financing on outcomes other than spending. And I provided a few estimates here, but I want to acknowledge that we know, and importantly, we know that care will be more equitably delivered under unified financing and that will waste less money. But I want to acknowledge that a lot of the things we really want to know is whether the delivery systems will be better. Will there be a greater focus on primary care and prevention? Will there be greater attention to social determinants of health and to questions of how to improve health outcomes for vulnerable populations? Will coordination and integration of care improve? Unfortunately, I cannot provide evidence-based answers to these questions, but I would say that arguably unified financing provides much better opportunities than our current fragmented financing system to make progress on many important outcomes that we care about. And beyond the clearly salutary effects of unified financing on equity and efficiency, there is nothing magic about unified financing that will necessarily lead to improvements in how care is delivered. Much depends on the mechanisms of accountability, on governance, and on the incentives created by the payment systems. But there's certainly every reason to think that we can do much better than in the status quo. Next slide, please. To summarize, as has been shown by many other analysts, if the federal government and the California legislature and the California electorate agree to create unified financing, then it would be possible to cover everybody and increase health equity, not spend more money and likely save money over time. I should mention that a variety of changes to the California Constitution would be needed to implement unified financing, and that voter approval of those changes would be required. And then finally, many design decisions would be needed, and that's the task in front of the commission. On behalf of the consulting team, we look forward to answering questions that commissioners and the public may have about the material I presented today, and to supporting the commission in its work moving forward. Thank you, and I open the Zoom to questions.
Thank you, Rick. So we're going to do this in two parts if we can. I'd like to be able to ask commissioners first to restrict their questions purely to questions for clarification and real questions of Rick about either specific slides or the assumptions underneath the analysis you just heard, or specific questions that pertain to your fully understanding what you just heard. Then we'll move on to either more questions or really comments and discussion with regard to the overall presentation that Rick just gave. And then thirdly, we heard just now that Rick is suggesting that there are 5 or 6 big buckets of design features that we want to make sure commissioners have a chance to opine about and help us understand which ones are most important to the commission to delve into in more depth. And so I want to take it in those 3 stages if we can. So the first stage is just questions for clarification of Rick and his consulting team, so his research team. So let me just look for hands up and go ahead and use the icon at the bottom if you have a question for Rick or about the presentation. Looking for hands. You can also, I see Richard Scheffler, I see you waving your hand at me, so I assume that is a question that you wish to ask. So Commissioner Scheffler, go ahead, please unmute and let's proceed.
Wasn't sure you'd call on me right away, but okay, I'll go for it. So it's really hard for me to put aside the previous discussion by our commissioners that spoke before, but I will try to do that, though I will tell you that it's clear that they need to be heard, and there's a lot we can learn from them. So having said that, I'll now follow the rules of the game, which is the technical questions that I might have for Rick. So the secretary told us and challenged us to think big and bold. And so I still want to do that. And so I applaud what Rick in particular and all the consultants have done. They've laid out the hand, they put the cards out on the table. We now know what the deck looks like and what the various hands look like. But there are really very sensitive things that need to be discussed that I think are the guts of us moving forward. And that is, how do you determine what budget a hospital gets? How do you determine what prices you pay people? How do you determine who gets care when? How do you really deal with what we've learned during the pandemic about systemic racism in the healthcare system? They need to be front and center on top of the hand that you've dealt, which is beautifully done technically, and you've hit every button. But the guts of being big and bold is to think in imagination and imagine a new world with a new healthcare system and what that would look like. And the vision to me is what matters, and that's what the commission is about. And of course, we'll get to the details and the numbers. Who determines the budget for hospitals, Rick? How do you do that? That's the technical question. And who determines the prices, and how do we do that? And do you have any reason to believe that anybody's been able to do a good job determining centrally at the state or state level what the prices are for healthcare services and what people need to be paid?
It depends on what you mean by a good job. I mean, I think that the Medicare program, the federal level has done a reasonably good job of determining prices for a whole variety of providers. You know, they work on those payment systems change over time, and they're never right, and they're subject to political influence from the provider side, which often results in troubles. But you know, they've done a reasonably good job. So yeah, I think it's tough to get this right, and in part because, as you know, there's a tremendous amount of income involved for providers, and they're going to find ways to make their preferences known. But I think we have examples in the United States and internationally of health systems that have worked over time at improving the way providers get paid. And by improving, I mean improving to get better outcomes for patients, and in some places for the most vulnerable patients, which I think we probably all agree is a
Well,
big
just
part of
if
the
I
goal.
could follow up, of course, you know that the Medicare program, the prices are essentially determined by the American Medical Association and committees that recommend what the prices should be. And eventually it's regulated by the Congress, and they approve the new prices. So when you're saying we should follow that, we should have a committee of doctors who recommend changes to the relative value scale, and we should have a vote every year at the legislature to say what the price increases need to be and what we would pay doctors and what we would pay hospitals, because that's exactly what happened. But I'm going to punt on that because literally the world's expert, as you all know, a member of our committee who worked on developing the relative value scale. Bill Shao can tell us better than I could, because I can only tell you what I've read about his work. So if Bill wants to continue this conversation, that's up to him. But I don't think you mean that you want the prices and of hospitals and doctors to be voted every year by the state legislature in California. If you do, then say so, because that's what happens now in the Medicare program.
I don't mean that, but I do mean that it is possible to have prices that are determined by public processes that will lead to some improvements over what we've got in the status quo.
Well, let me intervene, and thank you, Commissioner Scheffler. So we have a number of commissioners with hands up, and I'm going to take it in order of people who we've not heard from, and then those we have heard from. So Commissioner Chin Hansen, we have not heard from you today, and so your hand is up.
Thank you very much, and thank you for the presentation, Rick, of the array of materials. Given the background I have, you know, I also took a strong focus on the long-term services and supports component. And because it's kind of like either in or out, possibly in the calculations here, the fact that they aren't in, and given the kind of expenditure right now that occurs, I was just wondering, you know, what would be the factor that would encompass long-term services and supports? Because this is not only about, as we know, older people. These are oftentimes people experiencing disabilities and children and all. But needless to say, this is a huge part of the spend. And it then starts to touch into not just traditional nursing home payments, which are under the Medicaid system, but just the kind of comorbidities of people who have disabilities, coupled with the growing reality of dementia. So that if it's an all-in consideration, I just wonder about how to consider LTSS.
Can you say a little more about your question? I'm not sure I'm quite following the question.
Yeah, it didn't seem like it was a component, you know, it was a given in, you know, the all-in is primary care, basically medical services and dental, but LTSS, long-term services and support, is an aside, and yet it's technically an all-in.
Yeah, I did not mean to at all suggest it was an aside, but it was such a large component on the cost side that we thought it'd be useful to at least show what the estimate of what that cost is.
Okay, sorry. So that it is available, and I saw this the summative amount, but it is a major consideration.
Yeah. In terms of design, I mean, every element of what I presented is subject to the opinions of commissioners about what to recommend to the legislature and the governor about how this should be designed.
Right. Thank you.
Thank you, Commissioner Chin Hansen. Commissioner Wood.
Thank you. Thank you for the presentation. Just a couple of questions. And if I hope I heard this right. If I didn't, please correct me. But you kind of alluded that we might go in the direction of a fee-for-service model. And is that did you say that correct?
One of the scenarios that we for which we provide estimates is a scenario, and this was based off of some legislative proposals that have been made, would have fee-for-service payments to to physicians and other non-institutional providers. It envisions global budgets for hospitals and other institutional providers.
And with that scenario, you envision savings?
We envision on net some, 0.1% reduction in savings. We envision increase in spending from unwinding managed care, pretty substantial, 5% increase in spending from unwinding managed care, but savings from lower administrative costs, lower prescription drug costs, and on net, pretty close to zero.
I guess I struggle with that a little bit, because the entire direction of healthcare has been moving towards more managed care, risk-based organizations, Kaiser, for example, complete comprehensive health systems. I question that a little bit because of human behavior. Doctors may be in the position, dentists, whoever, faced with lower incomes might bill more services rather than fall within guidelines there. And I don't mean that in a disparaging way, but when you consider the direction we have gone in healthcare, more towards managed care, more towards whole person care, I think there's an argument to be made that assumption may not actually work out in the long run.
You know, we do estimate that utilization and spending would increase by about 10% for the 60% or so of Californians who are currently in HMOs or other managed care environments. And so that does lead to an increase in spending in and of itself. It is balanced by, other, the reduction in administrative costs and the reduction in prescription drug prices. And, at least in our estimate, and again, estimates are subject to uncertainty, but this is kind of what we get paid to do. On balance, it looks like pretty close to zero.
And then two final parts of that. Number one, I guess we don't really have the ability to negotiate a lot on drug costs now. A lot of that is done at the federal government. So that's an assumption that has to be weighed in here. I think that's an important consideration. And then the other part is, while I absolutely agree that you obviously have lower administrative costs, that's a one-time savings in essence. And then you have a new baseline. And so I don't think you can continue to count that year after year in the savings column, because once you eliminate that, that's no longer a part of the equation.
No, that's a very good point. And as in the estimates we present that in the first year of implementation, we expect, pretty much status quo level of spending, a little bit of savings. And then the question of, at what rate will spending grow over time is a crucial question. Unified financing, as we look internationally, unified financing approaches have had somewhat slower rates of growth of spending, both because of the imperative that if they're financed by tax revenues, governments say, this is all the money we've got. We're not, limited ability to or willingness to run deficits. And also because of more levers to control spending growth, particularly the price lever, which we don't have in the current system. I mean, Medicare has it and Medi-Cal has it, but private insurers don't have a price lever. And then there's the big question of, to the extent that cost growth is slowed, what's the effect? What's the effect on access, on quality, on availability of care? There is, I think, every reason to think that if cost growth is slowed halfway intelligently, and it depends on how much cost growth is slowed. If we said we were going to take cost growth down to minus 6% a year or something, I think most people would say, oh, that's not going to work. But there's probably some slower growth than under the status quo that is both feasible and consistent with improvements in quality and outcomes over time.
Okay, thank you.
Thank you, Commissioner Wood. Commissioner Shao.
Thank you. I have a question along the same line. You made these estimations, which actually give us some. Are you going to make these details available to the commissioners?
Certainly.
Like you just answered Commissioner Wood's question. Because
yes,
those assumptions you're making actually determines your answers.
Yeah,
you assume it's a fee-for-service payment system, and you based on because there are legislative proposals on that. But the reality is California already moved for half of them under capitation payment for integrated delivery. So if you assume you're going to go back, no integrated delivery and fee for service system, you're going to say, wow, a single payer system going to increase the cost that much, which in your estimation shows that. You assume unwind Medicare Advantage is going to cost 7% more. And I was wondering, how could that come about? And Senator Woods, Congressman, Assemblyman Woods, and a question to you explained it. Thank you. So my question is, are you going to make your detailed assumptions modeling available to the commissioners?
Of course we will, Commissioner Shao. We look forward to doing that.
Can I ask you when?
We're working on a schedule and in very ample time for you and others to provide responses or to provide your any comments you might make on that and to try to and to be able to incorporate your comments. You know, we're also working on trying to support the commission moving forward. There's another meeting June 25th, and we're trying to balance you know, competing priorities here.
Thank you.
Thank you, Commissioner Shao. Commissioner Pan.
Thank you so very much. First of all, I do share some of the same concerns that my good friend Assemblymember Wood brought up, which doesn't make sense. And also Dr. Shao, who I was a student of way back when at Harvard School of Public Health. And so I do have several questions about the analyses, which I won't bring up here, but look forward to seeing the details. I will point out, though, as a practicing physician who actually was in charge of a clinic. So I'm not the, you know, there's some frontline physicians here, including myself. And during the Great Recession, what Medi-Cal did to try to stop costs by increasing administrative barriers to care for patients. All right. And basically, so for, you know, the TARs, the various other things, believe me, you can get very expensive on the fee for service side. You can just do a whole bunch of things, you know, fax reviews, et cetera. By the way, the legislature was actually asked, and we did pass a cap on the total number of patient visits. 10 patient visits during the Great Recession. That was passed in the budget. Because I was in the legislature. By the way, if you have dialysis, imagine that you can only have 10 visits. And by the way, it's 10 visits, all visits, dental visits, medical visits, everything, right? So, you know, I just saying that when you have a budget crunch, there's all sorts of things government will do to try to control costs. May sound good, but I'm not so sure it was good for the patients. And then, of course, there was exceptions, but that was, of course, an administrative barrier to get the exception if they need their 11th or 12th visit, and how did you track all the visits? But the question I have for you, actually, so I'll just put that there. The question I have for you is actually one of the fundamental assumptions is that are people allowed to use their own money to buy their own health care outside of the unified financing? So this is actually true in many places. But for example, we have a public school system, but people can go to private school. So under your assumption, is that the case? People can, if they decide, if they have sufficient wealth, that they can go purchase their own services beyond? And is that included in the overall determination of spend in healthcare in your calculation? Or is your only calculation only the people who under the unified system, but therefore people who spend outside? And when I say people, it's not just individuals. A company may decide that, you know, I'm a global company, I want to provide standardized benefits to my employees, so I don't want to have differentials. That's a good HR practice. Something isn't covered in unified financing in California, I'm going to provide that for my employees to, you know, for even the ones in California, because they're going to provide it equally for all their employees, you know, globally or whatever. So is the assumption that people are going to be able to buy outside of the unified system?
In the scenario that we provided estimates where there is some cost sharing, we did assume that employers could top off that cost sharing and that to the extent that they're offering better benefits in the status quo, that they would improve or increase or reduce the cost sharing for employees. So we didn't make that assumption, and that assumption does lead to, you know, some increase in spending relative to an assumption where employers were somehow prohibited from doing that. We didn't make any assumption about people buying coverage outside of the universal financing system, which is a pretty complete set of benefits to begin with. And I will, although you didn't ask a question, I'll make one comment on your earlier observation about Medi-Cal. My first job in healthcare was as the director of policy and reimbursement in the Massachusetts Medicaid program. I was a young person then, and I'm quite familiar with a variety of strategies that Medicaid programs use to try to restrain spending growth. And I'm sure that under unified financing, in tough times, Unified Financing Authority might also resort to some strategies that we might think, not so sure about that. But as you know better than any of us, Medi-Cal is a program for poor people, and in California, it is, politics are much more favorable to low-income people than in much of the rest of the country, but still programs for poor people are often not treated the same way as programs for other people. And unified financing would be a program for all of us. And so there would be, restraints on the ability to take actions that would get a lot of people really upset.
Well, I appreciate that. I'm not sure those assumptions, but again, analysis. I would also point out, by the way, if we have federal mixing of federal dollars, we have the Hyde Amendment. So there probably could be a ruling from the feds, you want our money, no coverage of reproductive services, abortions, et cetera, and any pool that federal money goes into. That would be consistent with existing federal law, the Hyde Amendment, which of course I personally oppose. But I think, again, these are things we have to keep in mind. So we may actually have to create venues in which we can have other forms of financing to provide certain forms of healthcare that may not be consistent with federal policy.
Thank you, Senator Pan. Commissioner Comsty.
So I had a similar question as Professor Shao, and then I had another question. So I really want the consultants to show your work and the citations because it's really important with many of these assumptions made in the presentation that there are associated choices about system design that you're making that other commissioners have mentioned. And these system design choices have an impact on health equity and access. So it's really important that we have detailed explanations about the modeling assumptions and that they shouldn't be dismissed as mere obsession over numbers. So I really want the consulting team to be transparent, make its underlying data and citations and methodologies public to commissioners and researchers in the public, so we can check the work of the consulting team to ensure that it reflects the opinions of the commission and public input. We should see that schedule that you have right away. If you're still working on an Excel sheet with all these numbers, perhaps you can update them later as you go on, but we need to see those. And then my other general question that I had on the substance of the presentation, the health plan or intermediary approach appears to me to be a non-single payer approach that would maintain the healthcare structuring that we have and continue a fragmented system of competing health insurance plans. And I believe HMO health systems is what you're referring to. And I know you call them intermediaries, but these plans and entities appear to me to function as insurers. So they seem to be gatekeepers to care, and they are in the business of denying care. So I think I want clarity that this second scenario is a multi-payer system of insurance. And then the question that I had is, we need to are you planning to show the qualitative differences between these two scenarios? Because it's really alarming to me that the presentation compares the differences between these two scenarios as if it's only a matter of dollars. For example, on the chart on slide 39, you compare the single payer model and this multi-payer health plan scenario, and it appears that 5% less would be spent on health plans and HMOs because they would be able to deny care like they do now. And then there would be about 5.2% more being spent on administrative costs. So, I think we really need to make sure that we show these qualitative differences between the multi-payer health plan scenario and the single payer system, which would provide more care, free up more doctor time, wouldn't have narrow networks, wouldn't be incentivized to deny care. So, I don't think that other, the second scenario is unified financing. A multi-payer system of health plans is not unified financing to me. So, what in the world are you actually talking about? And can we have some qualitative differences between the single payer model and the multi-payer system that you're proposing?
We will provide, we're happy to provide a summary of the evidence about what is known about health plans and health insurers and how they affect spending and utilization and outcomes. And I hope that will be helpful to you and other commissioners. I suspect that other commissioners will have different views than you have about the advantages of integration and coordination in the delivery of care, but I will let other commissioners speak to that. When I presented that slide, I did say there are many other things other than dollars that are at stake here. And I hope that presentation is helpful as a starting point.
Yeah, I mean, I think what we need to have in the report is a discussion of the things that are not just about dollars. And, I'm going to press here a little bit because I frankly don't know what in the world you're talking about when you say that it's a system that's some sort of version of Medicare Advantage plus Germany, plus Netherlands, plus cover California. And I think you need to be very, very clear what this is, because I frankly don't know what it is.
I am trying to be responsive to concerns that we shouldn't be designing the system, and that those are issues for commissioners to discuss and make recommendations about. So we're providing, estimates of kind of high level scenario, as I said, with many of important design options to be determined.
Yeah, and I hear you, and I'm glad that you're saying that this isn't in the bag and that we're not 100% going to be talking about this in the way that you've presented. But it's very confusing to me because you're already producing results of your modeling, even though we haven't talked about the actual design we want you to model.
Okay, thank you, Commissioner Consti. So we are now at phase 2 of my design here in terms of what we're going to do, which is to now open the floor to just general comments about what Rick presented, maybe other observations or questions, perhaps other information that you're seeking, before we go on to the third phase of the conversation, which will be to look at specific design features that commissioners want to delve into at future commission meetings. So this is a chance now for you to provide, again, as I say, commentary, perhaps suggest different ideas, different options you want to look at. The floor is open to commissioners who wish to speak to this. Well, I see your hand up, Commissioner Shao, so take it away.
This is a comment period. I'd like to offer this comment. Those estimations given have many, many strong assumptions behind them, and that makes clear. Then they show the difference between the two alternatives. One is the so-called direct payment, other one so-called health through intermediaries. And there are many types of intermediaries, as Carmen already mentioned. So therefore, I would say it's premature to actually show these estimates before some adequate design features have been discussed and decided. So that's what I urge the consultants, the chair of the commission, and the commissioners to consider. Because, thank you.
I'm sorry, I didn't mean to interrupt you, Commissioner Shao.
No, I'm done.
Okay, thank you. Commissioner Maria.
Thank you, Rick, for your presentation. I share some of the concerns about wanting to understand. I know I emailed you about this, where your numbers were coming from and how you derived them. And I appreciate you sharing that publicly with us as soon as possible. I wanted to add some thoughts to the consideration of intermediaries versus direct payment, or what we call single payer. If equity is important to us, and we have agreed together that it is, we must leave the private health insurance systems in the past. The American Bar Association wrote, "White supremacy influenced an evolving private job-based healthcare infrastructure that deliberately excluded the Black population. The move to democratize healthcare access in this country has always been a civil rights issue, and private healthcare infrastructure has always been in direct opposition to that struggle, even those that pretend that they're not. While the enactment of Medicare led to the desegregation of hospitals, the continuation of private insurance exacerbates health disparities. These insurance companies have no place in a health system that center equities. They have never been concerned with equity. In fact, they are often working against it in spite of their performative gestures and PR campaigns. Take Kaiser, for example. Kaiser's recent settlement of $18.9 million to thousands of their Black and Latinx employees who sued them for racist practices in their workplace. Several employees from Kaiser have shared with me how the legal and executive structures at Kaiser whitewash any mentions of structural racism or inequality at their work. These disturbing practices happened there even under the auspices of former CEO, the late Bernard Tyson, a Black man. Kaiser's legal and executive team refuses to admit how racist the organization is systemically. Even when these intermediaries claim to care about equity, there's a whole PR campaign on justice and equity from Kaiser right now. They do their best to hide how racist their practices actually are. And this recent settlement exposes some of it, but the real story goes much deeper than that. And if this is the case for how Kaiser treats their employees, imagine what happens to the patients. This cannot be fixed. This is how this system was designed and how it operates, even under a Black CEO. We do not need to preserve these systems that have failed us and continue to fail us in advancing health equity, that say one thing in public and have other dealings in private. So long as private healthcare industry functions in our state, we will see the conflict between excellent, equitable patient care and profit played out daily. And on the losing end of that tug of war are the people who need healthcare the most: our farm workers, our rural and inner city poor, our children, our elders, and our working middle class. We must devise a new system of healthcare delivery in California, and we can with all this talent sitting at the table and the overwhelming public support for it right now. We can create innovative funding streams and eliminate administrative waste that mixed systems create. When we talk about savings, I care about fiscal responsibility. I know it's necessary to make something feasible, but what I care about most is saving lives, especially when I see whose lives will be saved through our actions. How much are those lives worth to us? What value do we place on creating a society where all Californians can have the opportunity to thrive? We are social beings, and COVID has shown us that none of us can be healthy when some of us are left behind. Single payer or direct payments can lead to the elimination of the medical apartheid that shamefully characterizes healthcare in California today. Continuing to uphold these intermediaries will continue a culture of inequity that's baked into all of these systems. If equity is a goal, we cannot use these intermediary structures, and we should stop wasting our time talking about it. We must develop a new system with equity at its core. AB 1400 is moving through our state legislature right now. Let's make ourselves of service and focus our efforts and energy in giving our legislators what they need to bring us equitable healthcare for all. Thank you.
Thank you, Commissioner Maria. Commissioner Phlox.
Thank you, and thank you for the presentation. I wanted to start by echoing the earlier statements of Commissioners Comsteed, Mariah, and Shao. I do think that this is an incredible group of people and an incredible group of commissioners, and I really welcome having more opportunity to dig into these topics and hear from each other, because I think that's where there's a lot of synergy. And as Commissioner Scheffler said, I think we can all bring a lot of vision that goes beyond some of this analysis, because I think it's going to take vision and thinking beyond the system we have now that is so broken to be able to get to where we want to go. And so I wanted to also build on what Commissioner Scheffler said in terms of comments on payment and the way payment and financing of the system, a unified financial system, is structured, because I think that's incredibly key in both to have a system that is affordable and not becoming with spiraling costs that are just unsustainable like the system we have now. And because I think it's at the heart of an equitable system, because this isn't just about controlling costs, it's about redistributing the wealth of our system. We have a very inequitable system. We have lots of resources in certain areas with hospitals that have marble lobbies and concierges. And then we have others where you're barely scraping by. And it tends to be the hospitals and the providers that are charging the highest rates are not the ones who are serving the lowest income communities of color or are, safety net hospitals. And so we need to also have a system that looks at redistribution and equity in the payments to providers, in the way we structure payments. And so I think that's a key conversation that can't be separated out from equity. And then going to both the kind of managed care and intermediaries conversation. On the unwinding managed care, I think we need to be really clear in distinguishing between the worst of managed care, which I think a lot of us want to get rid of, which is health plans that deny services and underpay and stall and put up all of these walls to people getting care in order to save money, which is the worst of it. And then managed care, which is actually about managing the care of patients, of coordinating care, of making sure that they're getting the right care, adequate care, appropriate care, and that people who have maybe the most challenges in accessing that, whether they're low income, disabled, not English speakers, whatever it is, chronic illnesses, that they are getting the attention and care teams that they need. And so I don't think that there's necessarily needs to be a distinction between intermediaries and managed care, which I think can be done in a way that is constructive. There's health promotoras. There are union trust funds doing really incredibly innovative work to lower costs and improve union member health. There are so many programs out there about helping to manage care that I think we could make much more institutionalized. That's not necessarily a health plan or a health system. And so I want us to be able to think a little outside the box and not think of an intermediary or managed care as a health plan, because I don't think that's the system we want. I think if our values are around universal, accessible, affordable care that's equitable and gets care to the people who need it most, who've been the most ignored by the system or gotten the worst inappropriate care, then there might be a role for intermediaries that's not profit driven.
Mm-hmm. Thank you very much, Commissioner Phlox. Senator Pan.
Thank you. I appreciate the discussion. I think what Sarah Phlox just said, I think is important to think about, the role of, how do we organize care and who's going to help lead that is going to be an important one. I should just point out, that yes, we have plans that do really bad things, but I've also had experience on the other side. So for example, when I was at UC Davis, we had direct payment from Medi-Cal for ICU care, for pediatric ICU care, which was denied year after year after year. And we found out that the Medi-Cal program just automatically denied. Now the hospital didn't follow up and say no, and we actually did an audit to find out whether the claims we sent, why they were being rejected. And we found out, first of all, they were automatically rejecting every single claim first off. So they didn't bother to look at it, they just rejected it immediately, and then check to see whether we'd go back and ask about it. And unfortunately, some of the billing people didn't. And it turned out they, when we went back and reviewed those claims, all of them were accurate. And essentially we were $50 million down the hole for care of children. A lot of poor children, Medi-Cal. Okay, this is under fee-for-service Medi-Cal. And then when we went back and said, hey, look, we didn't audit, there was no problems with our claims, you just rejected them. Medi-Cal turned around and said, oh, well, then resubmit all the claims. Well, these are claims going back 10 years. Well, if you can't submit each claim individually, too bad. So they finally negotiated and agreed to give us 30 million out of the 50 million. Because, all right, so the reason I tell this story is because it happens on both sides. It does happen on both sides, right? So so again, going back to our previous discussion about administrative costs and claim processing, fee for service is not automatically going to be easier than capitation either. Okay, I mean you can have bad players on both sides, so let's keep that in mind. It's not that, and so doesn't mean like everything's bad. I think as Sarah Flock said, what we got to think about is how do we try to have the infrastructure to set up for that kind of integration. I think when we looked at when you say fee for service versus plan, I mean we want to look at opportunities for integration of care, better management of care. We talk about actually under Dr. Shao talking about capitation versus fee for service. But the other thing I also just want to let me just make an observation, okay? Just an observation here is that in our Medi-Cal program here in California, so that's our single payer here in California over the last more than 2 decades, probably 3 decades, every administration, whether it's Democratic or Republican, under every legislature has moved more and more people into managed care, into a plan. That has been the trend. Okay, and it's not a practically unbroken one. So I've been in the legislature for 10 years under 2 Democratic governors, each governor, including, by the way, let's be very direct, Governor Newsom right now is proposing to move even more people into a health plan in our Medi-Cal program in this very budget proposal. Okay, now is that a bad thing? I think their goals are to try to improve the efficiency, to improve coordination and so forth, but they are moving more people into, and I can start ticking off the populations that we still haven't moved into, and I'm sure Senator Wood, and we can go and nod on that, but that's true. And I was also point out, by the way, as we were responding to COVID, even the very simple task of trying to deliver vaccinations and distribute vaccines, COVID vaccines to everyone, what did our state do in the end? We turned to a health plan, Blue Shield, to be the administrator for that. Now, again, we can say good or bad, but I think that if we're going to do an analysis, if we simply say we're not even going to look at the role of plans or intermediaries, whatever you want to call them, I think you're not going to get enough of a complete. You can certainly want to say I want an option without it, but I think if you're going to look at serious policy options, you're going to have to look at ways, also options in which there are these, because that has been the trend for the last 30 some odd years, not just in California, by the way, across the country. And I think it's going to be really challenging to simply say, well, we're just going to get rid of all of them like that. Now we can talk about, how do we get rid of the bad practices and keep the good ones? But the idea that, but the idea that we don't even look at the option of having intermediaries runs against, again, this is an observation, runs against what we've been watching happen in our government and our own government finance systems. And we've been talking Medicare itself, or the federal single payer. Again, more people in plans, Medicare Advantage, more people in plans every single year. So I just want to make that observation.
Thank you, Senator. I'm going to turn next to Don Moulds, Commissioner Moulds.
Thanks. I wanted to just ask a couple of questions about the presentation, because I heard some key points that I sort of feel like they're not captured in all of the comments. So first thing that I heard was that from your presentation, Rick, was that unified financing is going to save lives. The second thing I heard was that unified financing is going to be a far more equitable approach to healthcare, result in more equity than our current fragmented system. And then the third thing that I heard is even under very non-assuming financial analysis, we're going to save a little bit of money. So, so even if you don't assume that the legislature is going to come in, for example, and say anesthesiologists can only make half in California what they're making in the current market, even if you're paying the same prices you're paying right now, you're going to save a little bit of money. So it's going to be cheaper, more equitable, and it's going to save lives. Is that a fair characterization of the gist of your presentation?
It is a very fair characterization.
And then, so second question, the systems, so some of the alternative approaches that you are characterizing, the one in particular that I think is has been flagged, are systems that exist in the world outside of the United States. So, so the system that you were referring to when you're talking about non-governmental or quasi-governmental entities that manage care are more like the Dutch system or the German system, right? So those are not employer-based, correct?
Correct.
They are entities that are either created by the state or heavily regulated by the state, right?
Exactly.
And just from knowing a little bit about some of those systems, they also are far more equitable than the US healthcare system. They're far cheaper than the US healthcare system. Life expectancy in those systems exceeds US life expectancy. Incidence of chronic disease is significantly lower than in the US, right?
Mm-hmm. Yeah.
Okay.
Yeah.
And then last question. So just on the economic assumptions. Your analysis suggesting don't change any of the politics of healthcare, we're going to save a little bit of money. What are the sort of assumptions? And I think about Medicare as an example here when I think about the possibilities in this space, but is it more likely, less likely, or equal likelihood unified public financing that we would have more levers and be better capable of making progress on some of the outlier costs that you see in the US healthcare system?
Way more likely. I mean, there's certainly more levers and a greater imperative to use those levers. You know, the results will be very public. And when we see providers sort of abusing the public trust, the imperative to do something about that will be much greater, as well as more levers to make progress.
Okay, that's very helpful. Thanks much. I appreciate it.
Thank you.
Thank you. Commissioner Wright.
Yeah, no, I appreciate a lot of what all the discussion today. I don't want to repeat what others have said. I do want to take a step back from the intermediary discussion, because I think of it a little bit more broadly, which is, you know, what are the incentives of this new system to get to our goals of quality and equity and reduce health disparities and improved healthcare for everybody? And so I think we've talked a lot about about the potential for levers, and I agree that, you know, shifting to single payer unified health system has its own virtues by itself. But I think the real benefit is the fact that it provides the potential for a bunch of things, so that it's not magic, it's as was stated, but that it creates a platform for a lot of potential. And I think part of our goal is to try to design what that looks like. You know, for those of us who worked on the Affordable Care Act, I think we did something good by preventing the worst abuses of the health industry: denial of people with pre-existing condition, competition based on avoiding sick people. But we didn't really we didn't do enough to replace those incentives with new incentives that actually get us to quality, to equity, to improve care. And the question is, what are those? How can a single payer system get us there? And so, like, to me, a question of intermediaries is only like if it's in service of that, but we should get to the question of what are those accountability mechanisms? And so, is it how we pay? Is it how we? Is there how people are? How providers are being incentivized, if not held accountable, for these better outcomes and systems? And you know, I don't think we need to necessarily, and I think that should be the sort of the fundamental questions. And then, you know, whether that is, I don't even, again, the term intermediaries, if it looks like a health plan, then that's not as we know them in existing ways. That's less compelling. I know that there's some people who, when I read it, I was imagining more, and maybe we should clarify this, I was imagining more the health systems that exist now, right? Like here in Sacramento, you know, I could go to, there are a number of integrated or at least somewhat integrated healthcare systems that I could potentially go to. And is that what we're talking about? But again, I think the main question is, how do we use the fact that you have the purchasing power of the state of California to hold the industry accountable, and how do you do that through payment mechanism? What are the other mechanisms that you can use to do that? And that's what I would love that we can dive into more.
Thank you, Commissioner Wright. Commissioner Comsty?
Yeah, I just wanted to respond to a couple of the discussion points that have been floating. I want to make sure that we're not making this false dichotomy between single payer is fee for service and this other system, this other scenario is capitation and must be capitation. You know, as Rick already mentioned, you know, what his presentation was didn't include all for fee for service, and that you know, I know you might chastise me for talking about AB 1400, but that's what I know. I've been working on this bill for many years. AB 1400 has a combination of fee for service and institutional provider payments with hospital global budgeting, and the goal of it is to make sure that we're focusing on patient care, and that there are mechanisms that we can build in a single payer system that ensures that doctors, and not the government, not a health plan, not an intermediary, is making the decisions on care. And you know, I would like to have the opportunity to explain a lot of those details of AB 1400 and what we put in there to make sure that you know, if a doctor so chooses to to enter into a fee for service payment model, that there are checks on what types of coding and incentive mechanisms that might be driving a lot of some of the problems that people have already mentioned here today. But you know, I want us to pull back from this idea that, you know, fee for service is bad and single payer it uses fee for service, so therefore we need to dump single payer. It's just not true. And I want to respond. You know, what Sarah said is so true, that we need to step up to the challenge on figuring out options on integrated care that don't reproduce and rely on structures built on denial of care, options that don't interfere with the doctor-patient relationship. And you know, we need to step up to that challenge. And it's wrong of us to assume that the only way that we can get to care integration is through payment integration and through capitation. And I urge us all to stop, to take a step back and not kind of fall into this trap. And that there are a lot of options out there. And I'm very glad that we're actually having this discussion, because you know, we haven't had this before. And it's very nice to hear from all of you on these different things. So, you know, I'll leave my comments there.
Thank you. Commissioner Maria, and then Commissioner Hernandez.
Yeah, I really appreciate hearing from everybody today. It's been very refreshing to hear people's voices. I would just love to see a breakdown on, I was also confused when I saw this report on, wait, is this single payer or what is this intermediary? Why is this not, you know, what is this new language that we're using? And what would be helpful for me would be to understand the difference between leaving for-profit healthcare systems intact in California and the difference between eliminating them and having a publicly run system where providers are interacting directly with a publicly run system. I would want to see that both financially. For me, the way I understand it is when you have for-profit systems, some of that money will always be leaving the system. When it's not for-profit, all of that, all those resources and funding will be in there with the patients and the providers. I do hear the concerns that, Dr. Pan brought up and several others brought up. And I think that that's why we need this time to design features that will allow us to be more creative around how to avoid and to bolster a healthy system that can rely on the best of what we've done here in California thus far and eliminate the things that actually exacerbate health inequalities and exacerbate financial distress in our communities and start closing the loop on keeping our resources within our health practices. Thank you.
Thank you. Commissioner Sandra Hernandez.
I really appreciate the conversation today. Rick, thank you for the elevation that you did do on this presentation. I wanted to comment on a couple of things regarding managed care and how we compensate providers and sort of what we've learned over the years, notwithstanding the politics that Senator Pan mentioned. I do agree that it would be helpful to understand the levers that a single payer entity has by which it would control costs and potentially lead to all the outcomes that you described. Because we're talking about then in abstractions, and very much as our experience have been with trying those levers in a completely different system. So teasing those two things out, I think, would be enormously helpful. And I think we've talked a lot about structural racism here, directly and inadvertently. And I just think it's important to note it's not just in health plans. It exists in IPAs and in medical groups and the like. And so understanding how providers will behave in abstraction from how they're paid, I just think will be foolish, because we will likely end up with behaviors from providers that are not any better than what we're seeing collectively in the system that we have now. I tend to share the bias that managed care, and I'm not here talking about health plans, I'm talking about care coordination and care integration and looking holistically at people. In order for you to get a system like that, you have to compensate for people in that way. So I just wanted to make those comments in relationship to the conversation we've been having with other commissioners.
Thank you, Commissioner Hernandez. Assemblymember Wood.
Yes, thank you. And I'm going to read something here, and then I want to follow it up with a comment. And that's the mission of our group here. The Healthy California for All Commission will develop a plan for advancing progress towards achieving a healthcare delivery system for California that provides coverage and access through a unified financing system, including but not limited to a single payer financing system. And so why do I bring that up? I bring that up because it's important for us to look at all of the possibilities around a unified system. And then if we land in a place where we all agree that single payer in the form that it is being presented in other venues out there is the right way to go, we will have done a more robust, more thorough job of really analyzing all the possibilities out there. And so I would ask that people consider that, and not for us to focus on a single entity system here without looking at everything, I think is a disservice to the process. And our charge spells that out very clearly, but I know that's not necessarily going to be a popular opinion, but I bring us back to the charge that we were put together on this commission and ask that we look at this holistically. And if we do arrive as a consensus that this is the best way to go, then great, we will have done a great service to everybody through that process. So I respectfully ask that we follow the charge of the commission.
Thank you. Thank you. Point well taken. So before we take a break, I want to just ask if there are any commissioners who have not spoken today or not spoken yet who wish to comment or just even ask a question with regard to what you've heard so far today. I'm just going to pause for a second and see if any. Yes, Commissioner Anthony Hernandez.
Well, you know, as someone who's not steeped in the medical profession, but have a relative sense of the complexity of the issue, I want to second Mr. Wood's comments that we keep an open eye. This is an extraordinarily complex issue. And, you know, like other people who have mentioned the issue of equity and fairness, the medical profession has not been one, the current and the past, that has been very equitable, nor very fair. No, and these are generalizations, not very inclusive and caring about the poor and the excluded. So let's not glorify that, you know, if you do one system, all of our history will gone away. We are here to come up with a practical, realistic way that will put California in the vanguard of something that can be implemented, something that's within our means, something that will get us to where we want to go, but that we do it in a way understanding the consequences and the unknowns. So I would just say, you know, having a discussion, an open discussion, will allow us to make the best choices in whatever we recommend to the legislature and to the governor.
Thank you, Commissioner Hernandez. Commissioner Schneider.
Thank you. This has been a very interesting discussion. And I want to thank everyone for the opportunity to listen to it. So here's my read of the charge and my suggestion. The modeling that Rick has done, to me, lays out 4 different paths. One would be the direct service, fee for service, you know, hospital global budgets with long-term care services and without. And the other is the intermediary approach with long-term care services and without. And, you know, I'll let the legislators on the commission speak to this, but if I were in a position, what would be most useful to me is, how do all these work? Give me the pros and cons, and then I'll figure out which way I want to go. Because I can just tell you personally, there are some of these options I could just never sign on to, only because I think they're completely unrealistic. So that's just my personal professional judgment, right? And we could have 15 meetings about it and it wouldn't change my personal professional judgment. So in the spirit of trying to move the conversation forward and come up with something that I think is consistent with the charge and would be helpful for all concerned, because then you get to apply all the knowledge and expertise on this commission to different options, pros and cons, and now you've got something that has not been done before as an analytic task, as a policy analysis, and then the legislature and the governor have the benefit of that.
Thank you, Commissioner. Are there any others who wish to speak on the presentation or just raise comments before we take a break and then come back and do a quick exercise around future meeting topics and focal points? So I see Commissioner Scheffler waving madly at me. So Commissioner Scheffler, you have the floor.
Thank you. Thank you. Terrific discussion. I want to take on a discussion that I think is going to be important for the commission, was raised, and that's the word profit. And we live in a system now where we have a private delivery system of doctors and most hospitals and virtually all nursing homes and pharmaceutical companies. And they all need to make a profit. And it doesn't matter whether it's capitation or fee for service, because in every fee that a doctor charges or a hospital, there has to be a profit in it because they have to pay themselves and make a living. So you need to be careful about the use of the word profit. It's in everything endemic in the healthcare system, whether it's a capitation system, a fee for service system, or a salaried system. Everybody needs to make an income and basically a profit. So unless you're willing to nationalize the entire healthcare system, like the UK, and make all the hospitals and doctors employees, you can eliminate profits. So we need to have that discussion, whether we want to do that or not. Maybe we do, and maybe we don't. I go back to the reading and the discussion of fee for service versus capitation. Rick talks about the literature and health services research. He's made amazing contributions to it, but everybody who's published in this area and has written this area tells us repeatedly to move away from fee for service. Fee for service is what's driving the healthcare system to be inequitable and also driving up the cost of the healthcare system. In California, we are the leaders in the country in integrated delivery systems. Whether you call it managed care, I wouldn't, because that has a negative connotation, but we are the #1 state in the country dealing with integrated delivery systems. The numbers are in the 70 to 80% range. The secret sauce of California and why its per capita spending for a very rich state has always been below the national average can only be attributed to the use of integrated capitated systems. So the leap to move us to the rest of the 20% is something that I would urge the commission to think about. There may be a few examples where we still need fee for service, but the world is telling us that not only in California, but throughout the United States and throughout the world, they're moving away from fee for service. We need to move to capitated systems. The other advantage of capitated systems is it can deal with some of the equities in the healthcare system, because in the capitated rates, one can adjust for health inequities by communities and certain populations in the formulas that you use to risk adjust the payments and to deliver the money. So it gives us another direct tool to do that. You can't do that with fee for service. So we have an idea here to develop a new and better healthcare system based on a capitated integrated model for the entire state of California. That is the new vision. That's the secret sauce of California. It's doable. We're on the way to doing it anyhow. We can jump ahead and not wait the next 10 years for it to happen on its own. And we can also reduce costs dramatically by taking on such a system. So I think we need to go back and talk about the design of the healthcare system and what we want and what the vision is to deliver care, and then talk about the budgets and the estimates and how to get there. So I basically agree with all the commissioners that we need to start over. Quite frankly, if this was easy, someone else would have done it already. It's not easy, it's hard, and but I think we should take a real good crack at it.
Thank you, Commissioner Scheffler. So I'm curious, Commissioner Desert, because you are new, I know you've been listening attentively to this. If you have any just thoughts as you've heard your colleagues talk today, what goes through your mind? What questions do you have?
Eric Desert. My pronouns are she, her, and hers. It's an honor to be with you all, and I want to honor the work you all have done for 2020 on this incredibly complex challenge. Looking forward to working with you all. I have a lot of thoughts, Eric. I'm trying to be thoughtful and to let those who've been doing this work longer than I have. So I am listening intently. But certainly this group of people has decided rightly that equity is our guiding principle. And in the variety of options that we're considering, of course, based on a set of assumptions, there's a clearer option for equity, and yet we're discussing them as equal. And so my main question is how we approach our decision making. If equity is the guiding principle and we're looking at two options, and one is inherently more equitable for some reasons that other commissioners have explained, why are we still comparing them as apples and apples? So that's sort of a process decision in my mind, leaning into our value of equity, being bold and courageous in envisioning that future where many more Californians have true access to health services regularly. How do we get there? And where are the points in the road where there is just statistically and clearly in a way we can agree on an option that has more equity inherent in it? What are those paths and how do we follow them?
Thank you. Thank you. And Commissioner Lightbourne, I'm just curious to hear, as you've had a chance to absorb your colleagues' thinking today, what runs through your mind?
Well, I suspect as much as anything else, I mean, it's what's reachable. I agree that we've been sort of moving as a state into sort of integrated models of care. That's what we've sort of got immediately ahead of us in the Medicaid space. And to the extent that a unified purchasing system can advance that, that's wonderful. I would be very hesitant or doubtful about the system that was ultimately going to rely on a sort of a widespread fee-for-service construction.
Thank you. Thank you for sharing that. Commissioner Mario, your hand is up.
I just wanted to briefly respond to the point about profit, and I think we should actually have a deeper discussion on this, perhaps at a later date. So making a living is not the same thing as making a profit. So people do obviously have to make their livings. I work at a not-for-profit medical system at UCSF. I make a good living as a physician. But the whole point about evaluating this system that we want to design in terms of whether or not money leaves it is extracted for it for the benefit of shareholders or the benefit of executives versus money staying into the system. So when I'm talking about profit, I'm not talking about individuals making their living, which we all need to do. And I support all of us doing that to the best of our abilities, but creating a system where that funding is not extracted to the personal benefit of other people. Thank you.
Thank you, Commissioner. So let's do this. Let's take a quick break and then come back and summarize where we're at and then preview what we think lies ahead. So I make it to be about 10 of the hour. Let's come back right at 4 p.m. Pacific time, and we will resume at that point. Thank you. I will say, just as we warm up to the next hour and concluding hour of our meeting, that as somebody who professionally facilitates lots of discussions and does it both on now for the last year and a half on Zoom and previous to that many times in person, it is difficult to have a good, robust discussion on Zoom. But that was a good example of one where we heard lots of different viewpoints, and I think everybody had a chance to really speak their minds. So I appreciate that very much. I do want to, as we begin this next hour, we have a couple of things on our agenda. First, I want to turn it back to Secretary Galley to sort of summarize what he's heard, what you've heard, and then also to make sure we give ample room for some more feedback from commissioners, and then lastly, of course, public comment. So, Secretary Galley.
Yeah, thanks, Eric. And like Eric said, I am very grateful to have been a part of what was a really rich conversation. And I think from the comments, especially of the commissioners who responded most recently last, I think we all appreciate that we had one of the first really, clear back and forth, good dialogue conversations, could feel the continued passion and interest in people really lifting up why you were selected to be part of this conversation, because we each have broad experiences, but also special areas of focus and interest. And I heard that come out in so many ways. Appreciate the opportunity to be part of it, but also to consider how we do more of that moving forward. So thanks to those suggestions, and remind you that after this meeting, we'll send out a poll to ensure that we get people's feedback on cadence of meetings. And then we're going to spend a few minutes now. I'll try to summarize really quickly what I heard, but also give you all a chance to respond a little bit as we kind of move into a time where we plan for future meetings. Then I want to give as much time as we can to public comment. So Eric, if you can keep us to about 4:20 so that we can leave about 40 minutes to hear from the public. So first off, I think, and if I don't attribute the comment accurately to every person who made it, apologies, I tried my best. But I want to first start off by Commissioner Scheffler. Richard, your sort of point that we need to continue to think big and bold, and that's the moment that we're in. I know it's how I feel, very, very clear and important. And be really honest about kind of some of the features that we're contending with, right? Your point about fee for service, and that's been a key feature of driving up the cost of care, that it's maybe disputed a bit, but not very much anymore, that this notion of profit, and Rupa, your point about what is profit and how do we kind of think about profit, will continue to be an important piece. I really want to lift up Antonia and Assemblymember Wood's point about keeping an open mind, and that some of the systems and the history of these systems, I think both in Sandra and Antonia's point is that they haven't always been, even when doing the best they can to recognize their own structural racism, the inequities that are driven by them. And we want to be thoughtful about how the choices we're making really address those issues. Sarah, I thought your comments were so appropriate, that let's not just bucket everything about a managed care system into negative or positive, that there's features there that need to be dissected a bit to really choose what attributes have been helpful, beneficial, advancing our needs, but not all of them. And you outlined some of those, and I think a deeper dive into that may be warranted, so we know what we're thinking through in very specific ways, and not at that really high level. I think, Carmen, your point, again, you made many points, but one that I think is a direct response to the presentation by Rick is that let's not falsely identify fee for service and single payer together, that those do not, that this false dichotomy needs to be contended with, and we have to be thoughtful on how we position those statements and think about it. And then Andy, your point, which I think ultimately we want to get to, where we have a series of options that our conversations lead us to making some strong recommendations around. And you laid out the four as we have them here, the direct payments, the intermediaries with and without long-term services, and supports built in. I think that's a great thing to keep our eye on for down the road meetings, but I see us as having a little bit of work to do before then. And today's conversation gives me confidence that as we move in the next 10 to 15 minutes, and we don't have to decide it today, but I wanted us to have a little time to talk about, so where do we go next, right? So June, we have a meeting that is scheduled. And I suggest we keep it and we do more of what we did today, but with some focus. I think we need to spend a little bit more time digging into what the true deliverables are of the system that we're creating. One thing that I know all of us think about, but didn't get raised in significant degree, are things beyond the healthcare delivery system, things that are not responsibilities necessarily of what happens in the four walls of hospitals or clinics. We talk about them as social determinants, we talk about them as social drivers, and what is the responsibility of these systems that we may continue to invest in one form or another to drive towards improvements there. I think health, broadly speaking, we talked a little bit about the disconnect between health delivery and public health systems, and our interest, especially post-pandemic, to tie these together with equity at the heart of our mission. In this, I think we have to contend with, well, what are those deliverables and outcomes we want to see achieved by the healthcare delivery system? And what other systems in our social safety network broadly, not just for low-income people, but for all people, what are we going to require and tie healthcare to that delivers on things like food security, housing security, other things that often aren't formal parts of our system. And then a theme that I thought was really rich in our conversation was this question around accountability. What are the points of accountability, and how do we drive towards that accountability? I thought Don's comment was spot on. Rick's presentation said, we can save money, we can save lives, and we can deliver more on equity. But there's more to that conversation about that really is connected to that accountability and what the deliverables are that we want. So I think the question I have to the group that we should spend the next 10 or so minutes on is, where do we go with the June meeting, right? And we'll have more time, but I wanted to hear live and in as much color as you would like to provide. Eric, if you don't mind facilitating just a few comments on this. I think we have a choice. We can determine who, maybe a commissioner, who can help facilitate that conversation come June. But where do we want to focus? What sort of deliverables might be of interest to the group? And what sort of accountability features? We were talking about what the sort of attributes or features of the unified system might look like. Maybe there's one or two that individuals want to lift up and have become a focus of our conversation. Now we'll have a similar amount of time, so we could pick one or two, or one topic or two or even three to see if we can contend with. We'll determine that in between the meetings, but I wanted to just open it up to the commission and see what others think.
Well, thank you, Secretary Galley. So the question I hear being laid in front of us is, what is the starting point for June? Where do we want to go in June to lay the groundwork for future commission discussions and decisions? And I hear Secretary Galley mentioning perhaps the idea of, well, what are the overarching goals, and then what are the levers and incentives we want to build into a system, and then how does that system design accountability into it? So thoughts, commissioners? Is that the right track for us to be on? Is there a different track for us to be on? Commissioner Shell, I'm curious to hear your viewpoint on this.
I'm going to speak as an economist. Economist knows that you should start out looking at a goal you want to achieve, but then consider what constrains you. And I think what we're doing here is I think the commissioners all agree on the goals: equity, equal access, higher quality, affordability, and so forth. But that requires a new health care system. And that's going to disturb the political landscape. So putting my economist hat, what I think the whole conversation often lacks is this big elephant in the room, which is a political constraint. And we can come up with a visionary, noble design. But if you ask us to come up with something likely, politically likely to be viable, to be considered, then that actually may give us a different answer. And the discussion we just had about fee-for-service payment, really in many people's minds is there may be benefits, but I hate to say, empirical evidence in the United States and the world shows fee-for-service payment is really the worst payment system. Because the more you do, the more you get paid. And consequently, there's over-treatment, duplication of treatment, unnecessary treatment. However, politically, maybe that's the only viable approach, to pay the doctors and hospitals and other providers under that. So I would like to know, in the future discussion, are we going to consider the word, are we going to develop a likely viable option? Well, that's out of the picture. Because this whole debate I just heard about using intermediaries or not, like German system or Netherlands system, it's a political consideration. Germany could not knock out these nonprofit insurance plans, nor could the Netherlands. That's why they use intermediaries. But they really restrict their role, which is not discussed thus far. They really just they do not deliver healthcare, not like your Medicare Advantage, okay? So sorry I put that elephant in the room back in the scene, say, what is our charge? Is the political viability a consideration?
Thank you, Commissioner. Commissioner Ross.
Yeah, thank you, Eric. And just appreciations, Eric, just for the way you steward these meetings. And thank you, Mark, for being responsive and a great listener. Meeting got off to a rough start in terms of some things I'm sure you weren't thrilled about hearing, but you were a good listener and took it in, and appreciate that. Yeah, I agree with Commissioner Shaw on one issue, but I disagree on another. I'd like the opportunity, Mark, for us, and maybe it's not the next meeting, but two issues that came up today that I think we need to wrestle to the ground in terms of what we want is this question of intermediaries and fee for service. I mean, I'd like to see California move forward with unified financing mechanism, but not throwing away what has worked for California. And so that's a trick. That's a trick. We're gonna have to figure out how we, I like the term, I can't remember which commissioner mentioned it, might have been Commissioner Wood, but integrated delivery systems rather than a managed care, because managed care has such a boogeyman tone to it. But I wouldn't mind a deeper dive. You know what the vision of what we're trying to achieve is about, and looking at the questions of intermediaries and the question of fee for service versus integrated care in the context of serving that vision. And I really like Commissioner Flock's suggestion of let's kind of shake ourselves loose from today's commonly held definition of what an intermediary is. And let's think about an intermediary or the need for an intermediary in service of the vision we're trying to achieve. On the comment of political viability, we're gonna have to wrestle that alligator, but let's put that one off a minute. Let's do a bit more visioning about the system we want. If we make ourselves too crazy about the political viability of this too early, we might as well all go home. Whatever we come up with is gonna be unpopular. Let's just get over it. Or not popular everywhere. Let's say that. We're gonna have enemies coming from all kinds of places by the time this thing gets to the governor's desk. So let's not distract ourselves too early in the process with the political viability question. Let's let that one sit a little bit until we get closer to a shared vision of what we want. Thanks.
Thank you,
So,
Commissioner Ross. Thank you.
Eric,
Yes.
I just want to respond to Bob's comments, and I appreciate them, and just to Bill's comment as well about the political piece. I think our charge is to deliver a report that reflects our best thinking on the questions at hand, that we would deliver those to the governor and the legislature, those in the political offices to make those decisions. And, you know, I know we'll all be considering the politics and the viability, and Andy raised his views, and I know we all have them. So that will certainly mold our thinking, but the idea that we want to have this be a report that we believe on the principles and the information analysis we're all bringing forward represents that, and let the political folks wrestle that a little bit, not on their own, but with our best advice given to them. So I just wanted to echo that point that Bob made.
Thank you, Dr.
Hey, Mark, can you guys hear me? Yeah, I'm sorry, just one more thing. I've been off video for much of this call. I just want to explain why. I'm a brand new granddad this week, and I'm literally driving to see my new granddaughter. I've been tracking the conversation. I've been listening. I just haven't been able to be on screen. But every once in a while, as my foundation colleagues know, it's good for a foundation president to just shut up and listen. So it's
we
Thank you.
appreciate that.
Thank you, Commissioner Ross. So we have literally 3 minutes left before we have to take public comment for Assembly Member Wood and for Senator Pan to make final thoughts here. So if we could keep them brief, gentlemen, that would be great. Thank you.
Thank you very much, and I will be brief. Just a couple of things to consider. You know, and Senator Pan, I know he understands this, and so does Sarah in particular. Things that happen in the building, but if this was easy, we would have done this a long time ago. Every single thing we try to do to change the system meets with huge resistance from people who don't want the system to change. Every single thing. And you know, I know Dr. Pan has had some tremendous success and has more things out there, as do I, but it is really, really hard because the interests are so entrenched and it is so difficult. What I would like to see a discussion of at some point, not the next meeting necessarily, is if we're going to propose a financing mechanism, we also need to recognize and identify and discuss the obstacles to that, or the challenges. Let's not call them obstacles, call them challenges. What does that mean to federal law? What does that potentially mean towards California law? Things like the GAN spending limit, things like Prop 98 and a variety of these things, so that we actually have these as discussion items, so we can actually put them on the table. They're not easy things to discuss, and not everybody wants to discuss them. But I think if we're going to be realistic about what we do, there are ramifications to what we design. And that means we need other steps to be able to tick off as we make progress towards this solution. So thank you very much for the opportunity.
Thank you, Assembly Member. Senator Pan, we have about a minute left.
First of all, I think in regards to, you know, sort of the political constraints, what I would say is that I hope, I guess I would say is, let's not try to come up with like the perfect system, right? And so forth. What you need to do is come up with the options, right? You may prioritize different things, because in the end, whatever quote system we provide is to go through the political process, right? So I think it's not so much as Dr. Chow, like we want to limit ourselves, but I think we have to be more reasonable and say, look, you know, maybe this is what we prefer, but then actually this would be a trade-off, et cetera. These are the trade-offs, et cetera, and a set of options. Because, and then what happens is when it goes through the political process, people can go and say, okay, well, maybe it's this combination of things we prefer, versus trying to say, here's the perfect system. It's either this or nothing, because that's going to be politically very, you know, basically you probably will get nothing. Let's just put it that way. So so I want to put that out there. The other thing I also want to mention, because we talk about unified financing and we talked about leverage points and so forth, it's not the financing where the biggest fights is going to happen, although that's going to be a challenge. It's also who's exercising those levers. So you say government, well, who? governor, legislature, independent, Federal Reserve Board type system, et cetera. And then actually from an equity standpoint, we've been talking about equity from a delivery side, but equity from the, even from the decision-making side, right? So that's going to be important too. So I hope as we're talking about unified financing, realize not just the financing, it's who's deciding how those dollars are going to be spent. And whether it's broadly in terms of caps or other types of things, and that is something that we need to think about as well.
Thank you,
and then
Senator.
again, options, not just here's the one thing that we are proposing.
Thank you very much. All right, thank you all for that last discussion, and we are going to now move into the public comment period, and I will turn it over to my colleague Karen Bloomer to facilitate the public comment process. Karen?
Thank you, Eric. So we will now be opening up the chat feature for members of the public to submit their written comments that way. And as always, there is the option of emailing healthycaforall@chhs.ca.gov. And then we'll also take members of the public for verbal comment in order of the hands that are raised in the participant panel. When I do invite you to unmute, please state your full name and any affiliation you have. And please note that you'll have 60 seconds to speak, and I'll gently let you know when your time is up. All right, with that, Michael Leidy, please introduce yourself.
Thank you, Karen, and thank you, commissioners, for this opportunity and this robust discussion. I think it is not appropriate to make predictions about what is possible politically or what's possible, say, for example, with the federal government. That ends up being a defense of the status quo. And what we lack in this effort is leadership. And that's what I think we need from this commission. I definitely associate myself with the supporters of single payer. I would call out the comments of Don Molds and Cara Desert and Sarah Phlox in particular. Commissioner Desert said, hey, we've got a clear case for single payer on equity, on cost savings, and on improved quality of care. Those cost savings are generated yearly because what we don't spend on administration the first year in single payer, we also don't spend it in the second or ongoing years when the current system does spend money on administration. And I don't see how a system of intermediaries can cost the same as single payer given the other administrative layer. I think it's also important to understand that we're talking about saving lives and what a life's worth. I had the honor of serving on the Lancet Commission. They identified 436,000 excess deaths nationally in the US in 2018. Those are 43,000 excess deaths in California. We can save lives, we can save money, and we can produce equity through single payer. And we have to model that in order to understand it. Thank you, Karen.
Thank you. Thank you. Mary McDevitt, please introduce yourself and your affiliation. You have a minute.
Yes, hello. I certainly am enjoying watching the work of the commission. I have been following it since its beginning, and I'm really glad that Assembly Member Wood brought up the goal, which states that this commission is to work to provide coverage and access through a unified financing system, including, but not limited to, a single payer financing system. So I've been sitting here from the beginning of your work and waiting to have the single payer system included, which is part of your mandate. And I'm just disappointed that I haven't heard anything about it. Thank you.
Thank you. Taylor Jackson, please go ahead.
Hi, commissioners. My name is Taylor Jackson. I'm with the California Nurses Association, representing over 100,000 registered nurses statewide. As you've heard today, CNA is sponsoring a single payer bill with Assemblymember Kalra, AB 1400. The bill builds in features to dramatically improve equity for communities of color, rural communities, as well as people living with disabilities and seniors who need long-term services and supports to stay in their homes. We believe the commission should model this bill. It's important to accurately model the savings 1400 would provide by increasing reimbursement for primary care and paying appropriately for specialty and hospital care. Nurses also believe it's crucial to model multiple approaches to financing single payer that include a variety of taxes and to provide the online interactive calculator that shows the aggregate effect of different combination of taxes, including payroll with a small business exemption, business gross receipts, wealth, oil and gas extraction, sales tax with appropriate exemptions, and reductions in tax exemptions for large nonprofit hospitals and health systems, and any other taxes the commission identified.
Thank you. Thank you so much. Craig Simmons, please go ahead.
Hi, can you hear me okay?
Yes.
This question is for Richard Penn and Jim Wood. My question is, would you be in favor of implementation of a payroll healthcare tax if it included standardization of costs and was voter approved?
Mr. Simmons, I probably should add, I should have mentioned at the beginning that we're going to ask commissioners not to engage in two-way dialogue here. We're just taking public comment at this time.
Oh, okay, well then I'll change my comment. Years ago, I worked on a Kaiser Family Foundation and Teamsters Union funded project, which deducted 1 cent an hour from workers in canneries, actually, in California. And we had 3 mobile medical units around and gave a complete multi-physical to the workers and passed the results on to their private physicians within 2 weeks. So, you know, that was a number of years ago, but if a payroll health care tax were implemented, the Bureau of Labor Statistics holds that 60% of the US population is employed. In California, 60% of 40 million is 24 million people.
Thank you, Mr. Simmons.
So there would be a significant amount of money to cover all healthcare services and doctors, hospitals, prescription drugs, preventive care, if it were voter approved.
Thank you. Thank you so much. We see we have a lot of speakers. Bill Honigman, please go ahead.
Thank you. Can you hear me?
Yes.
Yes. My name is Bill Honigman. I'm a retired emergency room physician from Orange County. It is a travesty that the commission suspended hearings at the height of the COVID-19 crisis and consequently tacitly contributed to preventable deaths incurred by Californians due to the virus. Under a single-payer system, thousands more lives would have been saved and would still be yet saved if the commission had completed its charge and moved ahead by setting the mechanism into place for such a system rather than suspending hearings until now. The conclusions of the consultants are clear and echo those seen in studies done over decades or even centuries of analysis. The single-payer system will save lives, make healthcare more equitable, save money, and allow more controlling of runaway costs. What are we waiting for? Thank you.
Thank you. Thank you very much. Beatrice Sosa Prado, please go ahead.
Thank you, Karen. Good afternoon, everyone. My name is Beatriz Sosa Prado, and I'm calling from LA. I'm the Executive Director of California Physicians Alliance, CAPA. And along with other CAPA representatives, I am glad to have attended this important meeting today. CAPA believes that the commission needs to significantly spend more time amongst yourselves outside of these general commission meetings to adequately exchange your expert knowledge and to properly discuss and finalize your plan and recommendations. We hope that you can agree to this and to make those meetings public and provide us with an opportunity again to comment. California doesn't currently have a clear and detailed plan to get to universal healthcare. Therefore, CAPA authored the Roadmap to Golden State Care, a strategic, approachable, and realistic way to provide Californians with a healthcare system that is universal, just, and equitable. This roadmap is carried out in 3 phases to ensure that it's not disruptive to the current system and that each change that takes place is positive. I will contact the consulting team to get this document to the commissioners. Thank you so much.
Thank you. William Bronston, please go ahead.
My name is William Bronson. I'm a physician. I'm a member of the California Steering Committee for the Physicians for a National Health Program. And I was the medical director for close to 30 years for the Department of Developmental Services and the Department of Rehab for California. I have 4 points I'd like to make that are policy issues. Number one, we have been crashed in terms of public health in California. There was a major article in the newspaper today about the unfunding of more public health in California. Whatever the system is, it has to be grounded completely in changing the role of public health in the health delivery system, from illness care, medical, extraction of wealth, to wellness care. Secondly, I believe that we need to double the workforce and change its caste and class character. We need to deal with the health deserts all over the state. That means we need to provide comprehensive tuition for every public health college in the state that's doing any health professional training in order to deal with that and to build cultural sensitivity and competence in that group. Thirdly, I believe that we need to change long-term care to lifetime care, which means individualized planning to eliminate the lurch into institutional living and the lurch into impoverishment that Medicaid imposes. Single payer would wipe out Medicaid and would fundamentally change the framework.
Thank you so much.
Model. We should move towards that system.
Thank you. Ernest Isaacs, please go ahead.
Okay.
Yes, go ahead, please.
One meeting. My problem goes back to one of the very first slides that Mr. Cronick showed us, which says that he had a graph of the current costs and the savings under the various kinds, the 2 kinds of single payer systems, he said, and they were the same. It boggled my mind. Every analysis of single payer system has been done. The one for SB 562 from the Perry Complete people. Back in 2006, a Lewin report, all over the country. Everybody says that single payer systems will save lots of money, 10%, et cetera. I'm really concerned about the accuracy of his numbers. Currently, medical insurance companies are limited to a medical loss ratio of 80%, which means they skim 20% of their finances for advertising, for salaries, et cetera. Medicare overhead runs between 3 and 5%, depending on who you ask. There's incredible savings right there. We all know about the other countries. They have much better healthcare outcomes for vastly less money. I know Commissioner Kempsey wants to take a look at the spreadsheet that Mr. Cronick is using. And I suggest you take a very careful look to see where these really funny numbers are coming from. Thank you.
Thank you, Mr. Isaacs. Ruth Carter, please go ahead. Can you raise your volume, Ms. Carter?
Okay. Can you hear me now?
Yes.
Hi. My name is Ruth Carter, and I happen to be the chair of the California Democratic Party Senior Caucus, as well as the co-chair of the Marin chapter of the California Alliance for Retired Americans. If one of the things that we've talked about that I've heard spoken about today is, number one, I think we can all agree that our healthcare system needs fixing. However, when I hear about intermediaries, I begin to think about programs like Medicare Advantage, which has been problematic for those people who, for many people who were involved in its use. At the Department of Health and Human Services Office of the Inspector General report in 2018 reported that there were widespread and persistent problems related to denials of care and payment in Medicare Advantage plans. When beneficiaries and providers appealed pre-authorization and payment denials, Medicare Advantage plans overturned 75% of their own denials.
Thank you.
Thank you.
Thank you, Ruth. Erica Ferriston, please go ahead.
Hi, can you hear me?
Yes, I can.
Thanks. Right. So I feel like I'm repeating what we already know. We've had decades of studies. We have the rest of the world to look at. Every single study we've done from Stanford to Yale shows that single payer saves lives. It saves money. Had SB 562 been passed in 2017, the state of California would have saved $111 billion, and every California resident would have had high quality, comprehensive health care through this horrible pandemic. What we have now is a caste system. This commission, with the exception of Dr. Rupa and Carmen Comsty and Dr. Shao, is upholding this caste racist system, and we need to implement CalCare AB 1400 immediately.
Thank you. Sarah Sorokin, you're next.
Thank you. So my name is Sarah Sorokin, and I'm a mental health clinician and also a member of the National Union of Healthcare Workers. And working in an HMO setting, I see patients being denied the mental health care they need by a system where profit margins play a role in staffing decisions. Short-term profit-centered thinking, in which mental health care is rationed on the front end, leads to patients needing more expensive care like hospitalization, and exacts a heavy price on patients, families, and the communities in which they live. The despair, grief, trauma, and debilitation that results from undertreatment is unacceptable. Moral injury and burnout plagues the healthcare profession because we are unable to provide patients with the treatment they need. This is a human rights issue, and we have the capacity to fix it with a healthcare system not driven by profit. Although the Commission may also have other objectives, it is essential that the Commission achieve the goal it was created to bring about, creating a Medicare for All system in California. Thank you.
Thank you very much. Leah Schwinn, please go ahead.
Hi, my name is Leah Schwinn. I am the chair of the Nevada County chapter of Healthcare for All. There are many other savings issues that I didn't hear discussed today, such as having everybody in the same risk pool. AB 1400, CalCare, is so well written, and it goes into such detail. We want to have greater equity. We want to have a system that reflects California residents. And there's even equity on the boards of government written into AB 1400, and it also addresses the issues. I live in a very rural community in Grass Valley, California, urban centers. And I just want to say that I hope that we can move towards this single payer system. We hear it's so hard. It's so hard because it's not just profits that the for-profit system is putting their money into. They're putting it into lobbying and advertising. And so there's another place we'd save. Thank you.
Thank you. Brian Skolnick, please go ahead.
Hello, everyone. My name is Ryan Skolnick, and I want to talk about a few of the arguments made earlier during this meeting against single payer, but haven't been addressed directly yet. For example, this notion that Dr. Pan brought up earlier regarding the potential for budget cuts and care denial under a single payer system, this harm is entirely non-unique. Our fragmented for-profit system that exists right now, denial of care isn't just a theoretical, it's a rule. The difference is the money that we would save from doing that lines the pockets of shareholders and executives that play no useful role in the financing and delivery of actual healthcare. Regarding waivers that Assemblymember Wood mentioned earlier, we don't need statutory change to do single payer in California. The mechanisms are already there under Section 1332 of the ACA, which allows for a consolidated process that lets us apply for needed authorities under one application. The main requirement is we have to first pass a bill authorizing us to do single payer as current statute requires and as CNA and Dr. Sau have written about. This isn't a matter of feasibility, it's a matter of political will. Let's get AB 1400 done, and I want this commission to start doing its job and take it up.
Thank you. Ron Birnbaum, you're next.
Thank you, and thank the commission. I'm a physician in Los Angeles and also on the state Los Angeles or Southern California steering committees for Physicians for a National Health Program. I wanted to address a few of the things that came up earlier. So one is on the issue of fee for service. So both in the model, at least somewhat presented by by Dr. Kronik, and there was the modeling of for service for providers, global budgets for institutions. That's a structure that is in place in Canada and has led to less healthcare cost inflation than certainly in the United States, without a turn to certainly capitation in the outpatient setting. There was a discussion about care coordination that I think it's plausible that people sometimes need help navigating our system, although that's in part because of the excessive complexity of our system. But even still, the care coordination is often mixed up with utilization management, and those things I think should be separated. And finally, I would just ask Dr. Pan and Wood, who have the ability to stop bills in the legislature, to bring the same thoughts about letting the democratic processes or the discussion processes go forward in the legislature as they ask to happen here in the commission.
Thank you. Thank you very much. Carolyn Sanders, please go ahead.
Hi, Carrie Sanders at the California Pan-Ethnic Health Network. Thank you for continuing to discuss how we can create a healthy California for all as we consider ways to move towards a universal healthcare system. We can't build a universal payer system on a faulty foundation, and we urge you to ensure we don't miss opportunities to invest in racial equity and public health in healthcare this year. We urge you to fund the Health and Racial Equity Justice Fund to ensure that we strongly fund public health departments and CBOs to be key partners in universal systems. In terms of the analysis, we're concerned about the inability to assess the impact of the two models of financing on equity and quality. And we know that communities of color are not only less likely to be insured, but have lower utilization rates, even when they are insured. We agree with Dr. Hernandez that those disparities and barriers to accessing care are not necessarily going to go away just by moving towards fee-for-service or away from managed care. So we really would like to see more of an analysis of universal financing options on equity and quality, and to understand more about the different levers that are available, additional laws and regulations that would be needed to get us to greater accountability for reducing disparities and improving healthcare quality. Thank you.
Thank you. Michelle Brazat, you're next.
Yes, I wanted to talk about fee-for-service payments and just say it's not utilization that's driving up the cost of care. It's the prices. We can use anti-fraud provisions to rein in those few doctors who might perform too many procedures. And we can adjust payments upwards so that primary care doctors are paid fairly and adjust specialist payments downwards. Risk-based payments are currently driving massive vertical mergers that are actually driving prices up. Many small medical practices cannot stay open under alternative payment models because of the infrastructure requirements. As for integration, there can be healthcare integration without financial integration. Risk-based payments turn doctors into quasi-insurers. They may be forced to choose between providing care to a patient or meeting the expenses of their practice. In short, capitation creates an incentive for doctors to keep more of the flat fee by providing less care. Patients want to see the doctor or provider of their choice and get the care they need. Thanks.
Thank you. Thank you. Nancy Greep, please go ahead.
Can you hear me?
Yes.
Yes. Basically, most of what I wanted to say has already been said, so I'll be very brief. I wanted to comment also on the fee-for-service system, which is not the main cause of our increased costs in the United States. Our main costs in the United States are the enormous administrative waste that we have that's associated with these quote unquote intermediaries, and also drug prices. So in terms of fee for service, it just, as it's been mentioned, for example, in Canada, they have fee for service and they do manage to control costs. If you had a single payer system, you'd have a data system which would allow you to track utilization and identify where there was a problem with overutilization. And the other thing I wanted to say is that these intermediaries, which are for profit, as was said, the profit drains out into shareholders and not into public service. And we have to remember that some of these CEOs, they're making $20 million and $30 million. Those are healthcare dollars.
Thank you.
That doesn't belong in their pockets.
Thank you very much. Isaac Lieberman, you're up next.
Hi, can you hear me now?
Yes.
Thank you. I'm an elected member of the LA County Democratic Central Committee, a delegate to the California Democratic Party, a full-time hospital registered nurse, and a member of SEIU 721. Every study shows that we'll save money and save lives with single-payer universal health care as a human right. The best study shows that nationwide we'll save over 68,000 lives every year and over $450 billion every year. More than 85% of Democrats support it. More than 50% of Republicans support it. The conclusions are clear. Saving lives, money, and improving equity is what single payer gets us. Those arguing against it are almost invariably compromised with conflicts of interest and personal financial states. There's a reason intermediary financing are complex for legislators. It's because when we funnel billions of taxpayer dollars to private businesses like Health Net and Blue Cross and pay CEOs the $20 million just mentioned, a small fraction of that money, millions to hundreds of millions of dollars, find their way back to campaign funding.
Thank you, Mr. Lieberman.
It's pure corruption. That's the system under which we suffer.
Thank you very much. Philip Kim, you're next.
Hi, can you hear me?
Yes.
Great. Hi, everyone. My name is Philip Kim. I'm in Sacramento, and I am urging the Commission to model AB 1400, the California Guaranteed Healthcare for All Act. This is a fully designed single-payer healthcare system called CalCare that was introduced in the legislature in February. And you happen to have the foremost expert on the bill on the Commission, Carmen Comsty. All the details and design features are spelled out in the bill: an independent public governing board, comprehensive benefits, no cost sharing, special funding for underserved communities, et cetera. All it needs is financing, more than half of which can be provided from the existing federal waivers process. And I think it would be really useful for the Commission to explore different types of progressive taxation to fund the rest of the program. So I will echo the call for you to create a publicly available online calculator for members of the public and legislators to use to consider different types of financing. A word on the intermediaries option, which I think is very troubling, because if you're talking about managed care, what this means is less choice of provider and less utilization, and these are not good things. We want a healthcare system where people can use healthcare. That's the whole point of it. And we want freedom to choose any provider or doctor, no restricted networks, and intermediaries would not do either of those things. Finally, I urge the Commission to have a more transparent, open, and democratic process. I'm concerned that the consultants are dominating the process and not allowing the actual commissioners to discuss and drive the process. Thank you.
Thank you. Sarah Dean, please go ahead.
Hi, I'm a dentist, trustee of the South Coast Interfaith Council, and an activist with Healthcare for All Los Angeles. My family is deeply entrenched in the healthcare system. The healthcare insurance industry is interfering in the delivery of healthcare every single day. I want are you protecting? The healthcare insurance industry, what value are they adding to our health? The industry's agenda directly conflicts with the patients. Patients desire the best healthcare. The industry desires cost reduction above else. Why is anyone entrusted with designing our state's healthcare system trying to find ways to protect the insurance industry? Why are we debating single payer? We should be talking about how to pass and implement AB 1400. I have a kid who hates showering. He always finds a bunch of excuses never to shower. He knows it needs to be done, but he does whatever he can to distract and avoid. Fact remains, he still hasn't showered in days, needs to shower. Similarly, no more excuses about the political feasibility or how we will pay for it. I am tired of telling patients this is the best treatment for you, but it isn't covered. The immorality of that sentence should be the center of these discussions. Thank you very much. Let's pass AB 1400.
Thank you. Betty Dumas Toto, please go ahead.
Yes, hi, my name is Betty Dumas Toto, and I'm a person that is impacted by our profit first healthcare system. We have a model for universal healthcare system for all Californians, which would utilize a unified financing system, a single payer system, in our state legislature right now, and it's AB 1400. So instead of making this more complicated for yourselves, report on AB 1400, period. That's all you have to do. It's all there laid out for you. You don't have to worry about rushing to read this agenda and all this stuff 10 minutes before you get here today. Just read AB 1400, get it passed, get it implemented. And also for your consideration, capitation doesn't address the whole body in healthcare. In fact, it can be compared to decapitation, especially when profit is the guiding consideration. So please, if you have any questions about AB 1400, come to our Q&A every Sunday from 5 to 7 on Facebook Live Healthcare for All Los Angeles. Thank you.
Thank you. Richard Hung, please go ahead. And please do try to keep your comments to 60 seconds so we can fit everyone in. Thank you.
Hi, my name is Richard Nguyen. I'm a practicing pulmonary and critical care physician down in the South Bay area of Los Angeles. As a practicing physician, I've had countless tragic stories that exemplify the problems of our healthcare system. Patients who've been diagnosed with cancer, early stage, but while they're getting their insurance together, ended up advancing to late stage, advanced stage, and end stage cancer. I've had patients who've died waiting for insurance companies to approve of their therapies. I've had patients beat COVID, but now don't have insurance because they're now unemployed and are unable to have rehabilitation and now remain off of the workforce. The stories go on, and this is why physicians burn out. Even in our successes, we have failure. These failures were only amplified by the pandemic, and a single payer system would have fixed all of these problems. The public option or ACA or intermediaries would only perpetuate a healthcare system that is completely inequitable. This is why we need a true single payer system. Thank you very much.
Thank you. Mary Lopez, please go ahead.
Thank you so very much. Mari Lopez calling from Los Angeles, California. So as months have been spent already and now years discussing how to create a single payer system, while we already have a blueprint, health insurance costs, prescription drug prices are going up. Hospitals are billing people amounts that will bankrupt them, force the loss of their homes, and devastate their futures, as many have already experienced. And while we discuss, let me remind you that people are dying because they're not going to seek the care out of fear of financially devastating their families. So we need decisions, but not more discussion. So I really urge you to respond to the urgency of this time and begin taking action on AB 1400. Thank you.
Thank you very much. Ann Harvey, please go ahead.
Sorry about that. Yeah, I'm a retired family doctor and I worked for the County of Contra Costa until I retired. And I'm a strong single payer advocate, but I also do understand, I think there are problems with fee for service. There needs to be a lot of regulation and watchdogging because providers do sometimes provide care that is not only unnecessary, but that can be very harmful, as well as expensive, like procedures that are not needed, operations and coronary stents, and doctors have been convicted for doing these things. So to me, I think that what Dr. Scheckler and Jim Wood actually intimated, you should even consider a British style system where doctors, like all other healthcare providers, are salaried and don't have that either the worry about being a business person or lack of incentives for preventive care.
Thank you very much, Ms. Harvey. Do you need to move on to Nicholas Barcelo?
Good afternoon. Can you hear me?
Yes, can you turn up your volume a bit?
I can try.
There you go. That sounds better already. Maybe it was just
My
moving
name
closer.
is Nicolas Barcelo. I'm a psychiatrist and postdoc in health services research down here at UCLA. And it's a pleasure to address the commission. I wanted to echo an observation by Secretary Galley and the distinguishing healthcare utilization from truly determinants of health, and primarily the social determinants. And, you know, the most recent proposal for CalAIM suggests increased coverage for benefits related to social service needs. And I want to encourage commissioners to take a close look at the projections provided by consultants to evaluate the extent to which those social services are being covered to actually promote the health of Californians. And if it is within the scope of the commission's role to identify mechanisms by which cost savings in healthcare can be protected for the needs, social service needs, including housing and food for our Californians, which will ultimately be so important for their health.
Thank you so much. Jenny Chang, please go ahead.
Hello, can you hear me?
Yes.
Hi, I'm Jenny Chang, a delegate of the Democratic Party, organizer with California Alliance for Retired Americans. The Democratic Party endorsed AB 1400 and separately passed a resolution calling on the governor to request the federal waivers to secure federal funding, specifically for single payer system. And all of this happened without any hiccups. So let's talk political viability. The governor won a robust campaign on the virtues of single payer. This state very decisively voted for a primary candidate that made single payer campaign touchstone. If you are in this space more concerned with the anti-single payer forces that are being, that they're too entrenched to beat, maybe it is because you're working too closely with them and possibly benefiting from them. Yes. I think this body should consider workshopping AB 1400. That's a structured piece you can work with. But ultimately, this body is not writing legislation, but a guide. So let the legislature duke it out on how to make it more politically viable in its own time. Do center your work on the struggles of people. Do design the perfect system, that noble system. Do have courage, stand up and help us fight back. Thank you.
Thank you very much. Art Persico, please go ahead.
Commissioners, my name is Art Persico. I'm the convener of the San Francisco Gray Panthers. This commission can make a courageous breakthrough decision to do the right thing and recommend that the governor support single payer, which would give him the political cover he needs to fulfill his campaign promise to the voters of our state to enact it. Such a recommendation, if adopted by the governor, would buck the for-profit corporations' grip on our politics that intimidates elected officials out of supporting single payer. The lack of universal health care causes so much suffering and death. It defies the common good and the best interests of our fellow Californians. Please do the right thing. Recommend single payer to Governor Newsom. Thank you.
Thank you very much. And finally, Kathleen Healy, before I turn it back over to Secretary Galley. Kathleen?
Thank you so much. I'm a retired physician and co-chair of the California chapter of Physicians for a National Health Program. And you can try to pass 100 bills trying to fix and roadmap our broken jalopy of a health system, or we can join the group that sleeps well at night, having debt-free health care and doesn't need spreadsheets for bills. They're called Canadians. And yes, they have fee-for-service and no intermediaries. So we encourage the commission to use AB 1400 as their blueprint and work on funding options. And myself, as well as 3,000 other physicians in our Physicians for National Health program, support single payer. Thank you.
Thank you very much. And to you, Secretary Galley.
So again, I want to just thank the members of the public for their testimony, for being with us throughout this meeting. And I am just want to echo again the appreciation of the commissioners. The sort of cadence of the meeting and the conversation, I think
really began to uphold what some people have been asking for. And I'm glad we could get to a kind of conversation that it feels was well received by a majority of the commissioners. So we will be sending out, as I said earlier, the survey to kind of get us to have the conversation on number of meetings as was put forward by Commissioner a bit ago. And we will also be polling commissioners to determine how we choose topics for that June meeting that I think will be fashioned much like today's conversation, a bit more free-flowing and opportunities to engage. So with that, just a deep appreciation for each of you taking your time today, and look forward to seeing you again in June.